Ladies and gentlemen, Honorable Minister, PS, our development partners, dignitaries in your different capacities, protocol observed, we are ready to start. I've been advised that we amend our agenda briefly. We start with anthems. We shall do only one stanza, the national anthem, followed by the East African anthem, and then we shall have the prayer. May I request that we stand up for the anthems. I think we can remain standing for the prayer, which will be led by Christine. Christine is our registrar, Nurses and Midwives Council.
Praise God. Let us pray. Loving Father, we are humbled before you. We thank you, Lord, for choosing us to lead the health sector. We thank you for the leadership of the health sector. We thank you for all the leaders that appointed them. And we pray that, Lord, you will lead us to do your work, and your people shall enjoy, and we shall all rejoice. We pray that, Lord, you will join us in this joint review meeting, and we shall be able to deliberate issues of importance. We pray that, Lord, you will provide for everybody who has come. We ask you, Lord, to lead those who are still on the way, guide their footsteps. Father, bring them to join us as we talk issues which will bring glory to your name. We thank you. We pray that you enable the chairpersons of each and every session to lead us diligently and be with every participant throughout our stay here until we go back home. I pray all this in the name of Jesus Christ our Lord.
We can take our seats. Thank you, Christine. Honorable Minister, I request that I first take you through the objectives of this meeting before I invite you to the podium. Once again, good morning, ladies and gentlemen. Honorable Minister, we have a long protocol. We shall do the introductions with time later, but for now, allow me to welcome everybody who has come to this 29th Joint Review Mission, which is being hosted here today 1st and tomorrow 2nd. We will be here for 2 days, Honorable Minister. Honorable Minister, we have development partners participating in this joint review mission. We have chairpersons from districts. We have RDCs, those who have been able to make it, chief administrative officers. Of course, we have our development partners, civil society, implementing partners, the private sector. We have representatives from other sectors, other ministries, departments, and agencies. We have our hospital directors. We have commissioners from the Health Service Commission, DHOs. We have a keynote speaker who will be introduced. And of course, we have the Ministry of Health led by the PS and yourself, and the directors and heads of departments. And the objectives of this review are to receive and discuss the annual health sector performance report for the year 2022 and 2023. As you know, ladies and gentlemen, this is one of the major undertakings of this joint review mission, that during the joint review mission we have to discuss what we achieved during the year under review, and we are reviewing the period from July 2022 to June 2023. So we shall receive the annual sector performance report and discuss it today. We shall also receive an update on the progress in implementation of the 28th Joint Review Priority Actions. You recall in the last Joint Review mission, for the 28th, which I think was held early this year, to delay it a bit, we had undertakings and priority actions that we agreed on, which formed part of our MOU, our aide memoir, and we are supposed to see an update of what did we achieve of those undertakings that we agreed on as our priority actions in the last joint review mission. And finally, we shall discuss and agree on the health sector priorities and targets and major inputs required for the next financial year, 24-25. As many of you know, the budgeting process has just started, so this joint review mission is in good timing because it will guide as we agree and discuss the budget priorities for the next financial year. So basically, those are our main objectives over the 2 days, and we hope we should be able to achieve all the objectives or the undertakings of this joint review mission by the end of the day tomorrow. So at this juncture, I want to invite us to go into the official opening of this sector review, which now starts. And at this juncture, I want to invite the Honorable Minister to take your seat up, followed by the Permanent Secretary, followed by Jackie, the head of civil society organization, who will make a statement on behalf of the civil society. The PS will make welcome remarks. Then we shall have, as a tradition, we receive statements from development partners, civil society, private sector, and the head of local government association. So I want to invite now the President, Uganda Local Government Association, take his seat. May I invite the Chair, Health Development Partners, to take her seat. I think the Chair is the incoming Chair for next financial year. The current chair was UNICEF. I think they are handing over to USAID, if I've got it right. And the chair and a representative of USAID will make the statement on behalf of Health Development Partners. And of course, we shall have a statement from the country representative, WHO. May I invite Dr. Jonas, please, to take a seat. At this juncture, may I invite the PS to make her welcome remarks and welcome all of us to this 29th Joint Review Mission. Madam PS.
Honorable Minister of Health, Honorable Ruth Acheng, Director General of Health Services, the Health Service Commission representative, the development partners in the room, WR, UNICEF, USAID, and all. I need to get the whole list. I haven't got all the partners in the room, but I want to recognize you. I want also to welcome the civil society, our senior officials from the Ministry of Health, our senior officials from local government, implementing partners, the private sector. We want to welcome you today, and I want to thank you for honoring our invitation. We are yet to discuss what the sector has done, and we shall identify together the gaps and agree on the way forward. We have made tremendous progress. As all you know, our results that came out of UADHS were encouraging, but still we know that we have a long way to go, even to get better than where we are right now. We call upon each one of us to participate actively in these 2 days that we'll be here, because we want to pick everyone's input so that we continue together to implement. And with those few words, allow me to say you are welcome. Thank you very much.
Thank you very much, PS, for the statement and the welcome remarks. At this juncture, allow me to invite Dr. Luziga Simon to make a statement on behalf of the private health sector representative. Dr. Luziga Simon is the Executive Director for Nakasero Hospital, Kampala. He's a physician and a senior consultant.
Thank you. Good morning, colleagues. Honorable Minister, honorable members of Parliament present, Madam Permanent Secretary of the Ministry of Health, our dear development partners, distinguished guests in all your capacities. Once again, my name is Dr. Simon Ruzige. I'm the CEO of Nakasero Hospital, which is a member of the Uganda Healthcare Federation. And the Uganda Healthcare Federation co-chairs the Public-Private Partnership for Health Technical Working Group. Today I'm here and honored to give the opening remarks today on behalf of the private health sector. First, let me reaffirm our unwavering commitment to support the continued growth and development of quality healthcare in Uganda. This to date has only been possible through the partnership and collaborative relationship that we continue to share with the Ministry of Health. Development partners, implementing partners, district and city health teams, as well as our clients and communities across the country. The last year has seen us achieve new heights, such as the reinvigoration of the public-private partnership in Health Desk Office and the meaningful inclusion of the private sector in the Global Fund proposal writing process. However, we continue to grapple with maternal mortality and perinatal death and recognize the need to amplify initiatives to support child survival. Over the next 2 days, we will hear more on what together we can achieve, and the heart of this conversation is the need to improve the quality of care. Last year, we acknowledged the sector concerns raised about high cesarean section rates, inadequate reporting, and maternal and perinatal death in our sector. A survey and dialogue with the affected facilities conducted by the Uganda Healthcare Federation identified a wide range of factors driving these anomalies, including residual clients and demand created by previous financing mechanisms, to proximity of the facility, to transportation referrals from public facilities, and the functionality of private facilities in some areas where alternative public facilities may not have adequate human resources. This may concern some as a distortion of the health system. However, it also presents a case for strategic purchasing models and underscores the complementarity of services between the public and the private sector. The second concern raised previously was the low rate of data reporting by private facilities into the DHIS2. With support from USAID and in collaboration with the Division of Health Informatics at the Ministry of Health, we have co-created a digital platform that enables data reporting from private sector facilities directly from facilities to the DHIS2, not only cutting the cost of printing and delivery, but also offering providers with data analysis of the facility's performance. Furthermore, the system has the capacity to manage community health insurance schemes, which serves to support the sustainability of these schemes, which ensure access to affordable and quality health care in rural areas. This year's review of Uganda's sector performance has highlighted key issues: maternal and perinatal death, and weaknesses in the supply chain. We acknowledge that the private sector shares some responsibilities of some of these critical issues. Despite an increase in the skilled birth attendance, progress in reducing maternal and perinatal mortality rates has been slow. While we will continue to engage with consumers to sensitize them about high-risk pregnancies, we recognize the human capital capacity challenges, but we must continue to examine and appreciate the care continuum necessary to achieve satisfactory targets. Improving maternal and newborn health outcomes requires a collective effort. Investing in maternal and newborn health programs, infrastructure, and strengthening the supply chain are imperative. The public and private sectors can work better, more cohesively together to address these challenges sustainably with initiatives tailored to our health system. While a lot is said about stockouts and expiries in government facilities, similar inefficiencies in supply chain management also pose a significant challenge for Uganda's private health sector. However, the recently launched 10-year supply chain roadmap aims to gradually address this through improvements in understanding and skilling up our workforce. Through the USAID Strengthening Supply Chain Systems activity and e-learning platform with free-to-access courses are available specifically designed to support improvement in supply chain management, and this is open to both private and public health workers in drug shops, pharmacies, and dispensaries. Perennially, we reference public-private partnerships and how they can help improve service delivery by leveraging the strengths of both sectors. While there are challenges associated with the PPPs, careful planning and implementation can mitigate these risks. We need to honestly examine our undocumented PPPs and learn from their successes and scale them up. The time is now when we see our shrinking development partners' resource basket and we are seeking a pathway to self-reliance. For example, PPPs would pave way to private investors and can invest in research and development of new pharmaceuticals and medical equipment, as well as marketing these products in healthcare facilities in Uganda. They can also partner with the government to develop healthcare infrastructure under the model such as build, own, operate, transfer, and build, operate, and transfer. There is growing demand for nursing and care homes in Uganda, particularly for our growing elderly population who require long-term care. Investing in these areas can improve healthcare delivery and provide attractive returns for private investors. With USAID support, the Ministry of Health is currently drafting a 10-year private health sector strategy, which is expected to strengthen partnerships and deepen engagement to improve the stagnant indicators. It may also propose solutions to challenges faced by both the PNFPs and the PFPs, the private providers, such as non-payment for services at hundreds of private facilities across the country. Billions of shillings are lost to clients absconding without payments or simply failing to pay despite the legal redress sought by providers. The legal framework offered as a solution to collect payment is costly, resource-heavy to engage, and most often does not serve the purpose of recouping these funds for services consumed. However, we continue to engage clients and work with the regulatory councils and the Ministry of Health to support the introduction of the planned national health insurance, which will likely alleviate this. In conclusion, by working together, we can achieve better health outcomes for all Ugandans. The issues are still numerous, but we have the strategies and we have the solutions. The resources may be limited, but the commitment and hard work, we will get there. We look forward to hearing the progress and achievements in sector performance over the last year and appreciate everyone here for the role they have played to get us this far. Thank you very much for your attention. On behalf and on my behalf, I'm here on behalf of the private health sector. Thank you so much for God and my country.
Thank you very much. Thank you. Thank you, Dr. Ruziki. Please join me to invite Jackie Katana to make a statement on behalf of the civil society organizations. Jackie, you have the
floor. Thank you so much. Honorable Minister of Health, Dr. Ruth Acheng, Permanent Secretary, Minister of Health, Directors, Commissioners, Assistant Commissioners, the technical team, and all staff of Ministry of Health, and also all the other line ministries, OMDS, development partners, religious and cultural leaders, civil society organizations, implementing partners, and the youth, though I don't see very many young people. I don't know whether we have youth in the room. I'm Jackie Katana. I'm here on behalf of civil society organizations. I work for Faith for Family Health Initiative as founder and Executive Director. I sit on the HIPAC with other members I'm here to introduce, but also I represent civil society organizations on the Global Financing Facility Investors Group, hosted by World Bank at global level. Allow me to introduce the people who are responsible for this statement so that whatever comes here, so I will invite the CSOs, and this includes FBOs, community members, and NGOs who stand, who are in the room, so that you own this statement. Both HIPAC and non-HIPAC members. Thank you so much. So with those people standing, I don't have a liberty to speak from my heart like the PS sometimes does. So I speak on behalf of the CSOs. Greetings from the civil society fraternity in Uganda. And as civil society, we appreciate the Ministry of Health and partners for involvement and representation of CSOs in different Ministry of Health decision-making bodies. I already said we have around 5 CSOs that sit on the Health Policy Advisory Committee of Ministry of Health. We have quite a number of CSOs that sit on different technical working groups. But you've not also stopped there. You've guided and worked with the NGOs or CSOs and all the community-based and FBOs in implementation of different programs and projects. We don't take it for granted, even when it's part of the role that Ministry of Health and the partners do. This has promoted mutual accountability, but very important, strengthened multi-sectoral approach, collaboration, partnerships, and we look forward to more advanced level of CSOs engagement, right from the design, implementation, and closeout of most of these programs, and vice versa. Vice versa means it should be the same with CSOs. Also, they should involve the government when they are designing, implementing, and closing out programs and projects. And also, we propose that it should be people-centered. That means that all the processes should be consultative, to involve everyone. As SDGs say, we should not leave everyone behind. As CSOs, we commit to continue advancing community engagements and mobilization for increased uptake of healthy interventions. We also continue to work hand in hand with Ministry of Health and partners to mobilize resources for sustainability of health outcomes, but also ensure social accountability. We know that we are having challenges with uptake of services, and the performance report is yet to show us where we are not doing well. And as my colleague will say, some of the factors include poor health-seeking behavior of categories like the males, among others. And that's why my boss, Dr. Munjerera, is always talking about male engagement. We applaud the Ministry of Health and partners upon the recently released Uganda Demographic Health Survey report, and we are very excited that we've registered significant milestones in different and many areas, but to note, maternal mortality rates have significantly reduced from 336 to 189. We've seen reduction in child mortality rates and neonatal, though neonatal care is still a challenge. But the ministry is on top of things. Already you can see that our statement today keynote is going to be on neonatal. And that speaks to key strategies that we are going to devise today to ensure that that is not a challenge in the near future. But also very important that the theme is speaking to leveraging on community systems. And we are very glad that we already have a strategy, community health strategy, that is yet to be intensified in terms of rolling out. So Dr. Mwebesa, you're not very far when you said we don't need to be on the high table because we are supposed to be in the kitchen. We are community people. We are supposed to be delivering services, not giving speeches on high table. The Uganda Health Demographic Health Survey, the report highlights improvement in performance. I will not talk about so many, but I already said there's really significant TB, malaria, among others. But we also take note of those areas that have not improved, like teenage pregnancy is still really high. And we've also seen challenges in low retention of art We've seen high HIV prevalence among adolescents and young people. We've seen coverage in immunization is still a challenge. High malaria rates among the neonatals, increased non-communicable diseases, especially hypertension. So surely this review as objective 2 of this meeting is saying we are going to be able to look at how we review those areas and come up with game changer strategies. Some of the issues that were also identified, and once again, thank you for involving CSOs in the pre-joint review mission, field visits. So we had our colleagues work with you across the country to identify the issues that informed the report that we are going to receive today, but also the regional meetings. And most of these outcomes have been able to speak to most of these challenges that you, DHS, highlighted and the ones that we are yet to receive. We acknowledge continuous health system strengthening in all the pillars, especially the health information management system, both at national and district level to inform programming, decision-making, and improved digitization has made this much easier. But we know technology is a new area that we are all grappling with, so we call for more capacity building of health workers in that area, especially at subnational level. We do commend an additional investment, procure supplies and commodities, but we are still experiencing stockouts, especially at the last mile. That means for those people who are supposed to receive in the communities, and this will call for strengthening of supply chain management system, ensuring distribution and redistribution mechanisms which are effective. Also, we need to continue addressing aspect of timely disbursement, avoiding delays, and ensuring that allocation and expenditure is aligned to the real needs of the issues that we are identifying. And locative efficiency is very key. We thank you so much, Minister and the team, for upgrading Healthy Center 3 to 4 and completion of more health facilities. And this will go a long way to address the challenges of access to healthy services. And also, this does not only happen alone, this will also require effective human resources for health, and we commend the efforts to increase the salaries of the healthy workers. But the healthy workers in the room, I said we are in the kitchen, we see what you do every day. We are looking to how this increment is going to bear results. Because if the increments are happening and we continue to see absenteeism, then we'll say, was it really low salary or is it an issue of discipline and commitment to achieve the results that you're supposed? As earlier mentioned, the focus on community system strengthening is key. And once again, we appreciate the completion of the community health strategy. This will go a long way to harmonize different community structures and guide partners. However, we call for expedited implementation of the strategy, and we need to ensure that this strategy takes care of epidemic and pandemic preparedness, because this is a way to go. We don't know what will happen next. Today's COVID, tomorrow is Ebola. Improved universal health coverage and primary health care are key, ensuring health for all and addressing most of the highlighted gaps. But more important, Honorable Minister and PS and partners, we are waiting for the National Health Insurance Scheme. And we are glad that last week you mentioned the approaches and what is being done, but we can't wait, because that way we'll be able now to say this is a bullet, a magic bullet to achieving universal health coverage. Whereas there was a nominal increment in the health sector financing of 2023-2024, we are still far below the Abuja declaration of 15%. And this greatly affects progress and achieving the targets as per our National Development Plan 3. Now, with the low resources that mentioned, there is need to harmonize, strengthen linkages and synergies among partners to ensure efficiency and effectiveness. And this is for both development partners, CSOs, government, but also partners, especially the global financing mechanisms or health initiatives like JFF, Gavi, Global Fund, PEPFAR, so that they align resources, they strengthen linkages and harmonize all these interventions. Also, there's progress in development and completion of pending policies and guidelines, like the progress of merging the adolescent health and SRHR policy in the national health policy, We appreciate that you consulted us, but we need this completed so that we start developing the guidelines, and that way we'll be sure that we have a streamlined implementation. The consolidated guidelines on HIV, the national strategy and implementation of guidelines of sexual reproductive health, HIV, AIDS, and gender-based violence integration are crucial, but also it's important that we expedite the rollout. We have specific asks which come from already what we mentioned. One is that we continue to map and prioritize the poor performing indicators. I already mentioned a few. So I'm sure that by the time we leave here, we'll have approaches and strategies how to address that. We need to ensure effective supply chain management system to the last mile. Having enough stocks at the national medical stores, joint medical stores is not enough, but those who are supposed to get those medicines and supplies should be able to get them. Implementation of the community health strategy, the consolidated guidelines on HIV, the national strategy, and implementation of guidelines of sexual reproductive health, HIV, AIDS, and gender-based integration strategies and guidelines. We already asked these should be expedited. Universal health coverage, the ask was very clear. We are looking at the national health insurance as one of the key strategies among other innovative financing strategies. Harmonizing, strengthening linkages and synergies of different partners to avoid duplication and wastage of resources. And lastly, we ask for more meaningful of CSOs in all processes, programming, design and implementation and closeout, but also we are talking about mutual accountability. As the government does that, also CSOs and other partners should do that. Honorable Minister, last week in the Safe Motherhood Conference, you pledged that you're going to revive the Accountability Forum. And that way, that's when we'll be able to harmonize and discuss these issues. We are looking forward to that. Thank you so much on behalf of the CSOs.
Thank you very much, Jackie. On the issue of high table, I shall find myself. So we shall sort that out at a great time. So, ladies and gentlemen, allow me to invite Mr. Wawhinga Richard Aboki to make a statement as President of Uganda Local Government Association. Mr. Wawhinga is Chairman LC 5 in the Outdoor District. And he's serving his third term, I think, as chairperson. And we are going to give him the fourth term.
Thank you very much, DG. The Honorable Minister of Health, Dr. Jane Ruth Acheng, the Honorable Ministers of State, the Honorable Members of Parliament, the Permanent Secretary, Minister of Health, the Director General, colleagues, district chairpersons, RDCs, local government accounting officers, development partners, country representative, World Health Organization, members of the civil society organizations, the media, distinguished ladies and gentlemen. I salute you and bring you very warm greetings from Uganda Local Governments Association and the member districts and lower local governments throughout the country. Honorable Minister, allow me to congratulate the Minister of Health upon holding the 29th Health Sector Joint Review Mission under the theme Leveraging Community Health Approaches and Systems as Catalysts for Strengthening Population, Health and Safety, with the ongoing efforts at local government to prevent and control the spread of communicable diseases and non-communicable diseases through the use of community health workers. Honorable Minister, on behalf of Uganda Local Governments Association, allow me to congratulate you for the milestones achieved under your stewardship of the ministry, especially in combating and being a frontliner in the fight against COVID-19, the Ebola virus in Mubenda and Kasanda districts, and the effects of hepatitis B, and now being out there to fight malaria through giving the mosquito nets countrywide. We don't take all these achievements for granted, and as local governments of Uganda, Honorable Minister, we congratulate you and the entire team for these great achievements of our time. I want to appreciate the Minister of Health for inviting Olga to this meeting. And in this brief statement, I will draw your attention to the annual conditional grants negotiations agreements for the financial 24-25 as enshrined under Article 193, Section 3 of the Constitution of the Republic of Uganda as amended. And I think this speaks to objective number 3, which the DG pointed out, that as we make this review, we are also projecting into the financial year 24-25. And we want to congratulate you and thank you, Honorable Minister, and the PS for constituting a team that we engaged with during these sector negotiations, which we held in the month of September at Piatto Restaurant. You had a well-constituted team, and whatever we discussed and what we shall share here, we believe shall be implemented by the Ministry of Health. We note, Honorable Minister, of the poor partner distribution and coordination, those that are involved in those that are associating with the health ministry. We did agree that we shall strengthen partner coordination and distribution among local governments to enhance basket funding and reduce on vertical projects. We agreed with your team, Honorable Minister, that the Minister will provide to Uganda Local Government Finance Commission the list of all donor partners in local governments and their respective contributions to local government budgets by the end of this month of November. Honorable Minister, we appreciate the newly approved local government staffing structure at Health Center 4s and Health Center 3s. We note that Health Center 4 has been given 5 medical doctors at a level of a principal, a senior, and 3 medical officers. Honorable Minister, we appreciate this, and we look forward to quick implementation of this structure. We note that whereas the structure has been approved and provided, we are lacking the will from the Ministry of Public Service to allow us to recruit staff. Honorable Minister, at this review mission, we pray that by the end of this mission, we commit that we are going to engage the other sister ministries to allow us to recruit the much needed staff to implement the structure as already disseminated and provided to us as local government. Honorable Minister, on local government health performance indicators in the PBS, we note that the indicators for local government health and other service delivery areas have not been captured in the new reporting system developed by National Planning Authority. Parties continue to refer to ministries instead of programs, among other prevailing gaps. Local governments had 27 indicators, and if monitored well, they could cover all aspects of health, but these indicators were not captured on the program budgeting system. We recommend that the Minister of Health, working with the National Planning Authority and the Minister of Finance, should consult local government heads of departments and local government specific performing indicators to be included in the PBS during this time of budgeting going forward. Honorable Minister, we note that the communication of IPF to local governments sometimes delay, And by the time we get the communication, the disbursements have already been made and we are in the middle of the implementation. As local governments, we pray that the Ministry of Health, working closely with the Ministry of Finance, should make timely communication of all the funds disbursed to the local governments to ensure timely implementation and to help us avoid returning these monies at the end of the financial year. Honorable Minister, we report that the establishment of regional medical boards has delayed to perform the role they are supposed to do, and as a result, our officers continue being disturbed, especially those that are supposed to be attended to and retired on medical grounds. We recommend that we disseminate to local government the guidelines for implementation of the medical boards at regional level, if possible, by December this year. And we call on the Ministry of Health to allocate and provide funds to regional referral hospitals to functionalize the medical boards at that level. Honorable Minister, on PHC non-wage and PHC development, we note that the grants provided to local government, especially primary health care and development, primary health care, non-wage and development continue to decline, especially in the last financial year and this current financial year. This deprives local government of capacity to undertake on any major capital investment at health centers. We recommend that the Minister of Health should review grant allocation formula and make proposals by the end of this current financial year to enable us to have a smooth ride in the coming financial year. Honorable Minister, we call on your ministry to fast-track the establishment of the National Health Insurance. My sis has already alluded to that. This should have happened yesterday. We believe it is rather late, and we call upon the Minister of Health to fast-track this. And I have no doubt, Honorable Minister, this is within your calling, and it can be achieved during your tenure at the helm of the Minister of Health. We recommend, as local governments, in consultation with the Minister of Finance, that we take steps to functionalize the AIDS Trust Fund. We know that this country has had a challenge of HIV/AIDS, and we have time and again talked about a fund to address these challenges. We invite you, Honorable Minister, and at this engagement, that we come out with concrete steps on functionalizing the AIDS Trust Fund going forward. Honorable Minister, we appreciate the U-Gift Uganda Intergovernmental Fiscal Transfer projects under your docket as a ministry. We appreciate that these projects have taken ground and they are giving us a new face as a government in improving Health Center 2s, Health Center 3s. There is reasonable progress down there. We must appreciate that. And we note that the hybrid, though with its challenges, has given some yields, but it can perform better if we reduce the lots allocated to one contractor to a maximum of 2. I think this has been general consensus, and we pray, Honorable Minister, that it should be implemented in this current and in the next financial year. Honorable Minister, as the situation improves in terms of infrastructure, we pray that it should also improve in as far as distribution of medicine is concerned. While we improve on the structures, we do attract a mammoth crowd to our health centers because they have their confidence restored. And this does not, therefore, resonate well with the current budget on drug allocation for Health Center 3s. We call for an improvement in the budget of the drugs for Health Center 3s, but also we call for timely deliveries of these drugs to our health centers. In the last financial year, Honorable Minister, we performed quite poorly as far as drug allocation is concerned by national medical stores. We pray that national medical store improve on this, so that if we have to supply it every 2 months, let the cycles be followed and let the drugs be received in a timely way. Otherwise, going to health centers and you are told you go and buy drugs from the pharmacy does not make a lot of meaning and does not give us good credit as government anyway. Honorable Minister, we must appreciate the invitation, because during that engagement we recommended that we should be invited for these review missions. We are happy this has been done in a timely way, and we pray that it continues so that we look at local government and Ministry of Health as key partners in as far as health service delivery is concerned in this country. We are concluding with the service delivery zones for general hospitals. We note that whereas Ministry of Health has assigned local government regional referral hospitals coordinate service delivery, zones have not been clearly issued to general hospitals as contained in the last year's agreement on page 20 of the Ministry of Health budget guidelines, referred 23-24. We also note that new local governments did not have general hospitals as required by policy. As Uganda Local Governments Association, we recommend that we upgrade health center force to community hospitals in local governments, especially those that do not have general hospitals, so that they are able to provide basic services to their respective local governments. And we call on the Ministry of Health to issue zones to local government in the guidelines. I had forgotten one thing to do with school health services. As I conclude, Honorable Minister, local governments note that the guidelines on school health services have not been disseminated to local governments to aid service delivery in the schools. We recommend that the Ministry of Health should disseminate guidelines on school health services during this engagement, but also down to the local government and the lower local governments, so that we are able to deal with school health services in a more coordinated and very informed way. Honorable Minister, we have ambulances down there. Some have been donated by a number of donors, but these ambulances are not captured and cannot be supported. Some have not been repaired for some time, and some cannot be repaired by the ministry because they are not part of the ministry inventory. We are doing the same work, and these ambulances are helping in improving the quality of health care in the countryside. We pray that these ambulance systems are strengthened, that guidelines are issued in a more coordinated and centralized approach, so that together we are able to save the lives of our people, more importantly the mothers, who sometimes need urgent attention to reach the nearest health facility. Once again, Honorable Minister, we thank you and the Minister for inviting us for this engagement. We undertake and pledge that we shall continue working towards improving on the quality of health services in the country, with the Minister of Health as our key partner. I thank you for your attention.
Thank you very much, Chairman, President, Uganda Local Government Association. Now allow me to invite Dr. Rose Chono Okot, who is the Chair, Health Development Partners 2024. Rose is a team lead, Health System Strengthening at USAID. You have the floor, Rose.
Thank you, Dr. Mwevesa. Good morning, ladies and gentlemen. I'm standing here on behalf of the Health Development Partners, and I think I'll borrow a cue from the civil society rep who asked her colleagues to stand up. So just please do stand up, development partners in the house, for recognition. You may be seated. So I will also be making these remarks. They are not my personal remarks. They are a reflection of our thoughts as health development partners. So Honorable Minister, members of Parliament, the Permanent Secretary, Minister of Health, the DG, representatives from local government, representatives from the civil society, representatives from the private sector, all protocol observed, ladies and gentlemen. On behalf of the Health Development Partners and the outgoing Development Partners Chair that was taken over by UNICEF, supported by the incoming Chair, USAID, and the Secretariat WHO, I am honored to extend our appreciation to the Government of Uganda and the Ministry of Health for hosting us at the 29th Joint Review Mission. As you may be aware, many of us were here a few months ago, and we congregated for the 28th JRM, and that was after a protracted break as a result of COVID, which could not allow us to meet together for events of this magnitude. Honorable Minister, your presence here today, meeting together with partners and stakeholders, is a testimony of your leadership and dedication to build strong partnership to advance Uganda's health development goals. The JRM provides a platform where we can all collectively take time to jointly celebrate our successes, reflect on areas where we need to improve, and identify opportunities to do things differently, with the end goal of improving health services in alignment with the National Development Plan 3. Over the next 2 days, we will get to hear results from the annual health sector performance report for the year 2022-2023, and we look forward to developing actionable solutions to address health sector performance gaps. While here, let me take this opportunity also, just like previous speakers, to congratulate the Ministry of Health, the Honorable Minister, and your team for the recently released results of the Uganda Demographic Health Survey. It clearly showed significant reductions in maternal mortality, infant and neonatal mortality, and similarly, heartening significant increase in deliveries that are happening at the health facilities. At the same time, the survey highlighted suboptimal vaccination rates, moderate reduction in stunting, relatively high pregnancy deaths, associated deaths, and we still need to do some work in relation to uptake of family planning. If these issues are not addressed, they could impede Uganda and our ability to meet our global sustainability development goals. As the Health Development Group members' representative, we want to draw your attention today specifically to 3 issues that we believe, if we address, can improve the overall performance of the health sector. First, we are thrilled that at this 29th JRM, the theme is community-focused, and it emphasizes a renewed focus on communities to spur improved health outcomes. We as development partners strongly reaffirm our commitment to support the Ministry of Health in your efforts to strengthen primary health care while building more resilient community health systems. The recently launched National Community Health Strategy lays the foundation for addressing Uganda's overwhelming preventable disease burden at the community level. To do that, we must leverage integration. I know the PS, this is one of your strong issues that you like to talk about. So we are 100% in agreement about the issue around integration. It is not uncommon for community workers conducting household visits to provide child vaccination, malaria test and treatment, HIV prevention and treatment services, TB care, and interface with vulnerable pregnant women, adolescents, and children. We hope that the ministry will provide strategies and service standards on how to implement these integrated services in a more cost-effective and sustainable manner so that Ugandans can deal with the emergence of pandemic promise of a formal community health extension workers cadre that will sustainably improve primary health care in Uganda. These community health workers, whether they are volunteers, they range from the CHUs, VHTs, peer mothers, lay counselors, youth, women groups, they all remain our foot soldiers for service delivery because they are providing critical health services and prevention messages at vulnerable households' doorsteps. As development partners, we look to the Ministry of Health to provide the leadership needed to make the community health strategy a reality. Secondly, Uganda, like many other countries, is still recovering from the effects of COVID pandemic that eroded the financing landscape and resource envelope needed to finance the health sector. While the National Health Accounts of 2020-2021 show a reduction in out-of-pocket expenditure, that is a bright spot. It showed that the health sector is still highly dependent on external funding. The government of Uganda's nominal budget for the health sector increased in the past fiscal year, but it still fell short of the Abuja target of 15%. Moreover, nearly 60% of external resources, such as Global Fund or that from Gavi, still remains unabsorbed. Where funds are used, concerns still remain around timely accountability from the local government and the Central Ministry of Health. Uganda and we collectively must find ways to sustainably finance the healthcare through providing domestic resources. To this end, the health development partners keenly wait for the National Health Insurance Bill to be discussed in Parliament again and ultimately lead into signing it into law. We also urge the Ministry of Health to find innovative ways to improve budget absorption and efficiencies so that the resources are channeled to address the health system challenges that currently impede quality health services. Honorable Minister and Madam PS, we look to you for your continued support to increase budget absorption, accountability, and ensure value for money for all resources coming into the health sector, whether it's from the government of Uganda or external resources. Finally, let me take this opportunity to thank all health workers who remain our heroes at the front line of delivering health services. Honorable Minister, we applaud you and your team for working tirelessly to secure additional resources to enhance health workers' wage, almost twofold on average. We also congratulate the Ministry of Health for revising its staffing structure that increased approved positions from 53,000 to 135,000. As development partners, we urge the Ministry of Finance to allocate the resources that are needed to implement this new staffing structure. It's almost a threefold increase, and we know that it requires significant resources. And we look as well to the Ministry of Local Government to help fill those posts where resources exist. We hope that the strategy will lead to increased staffing rates for critical cadre and support the Ministry of Health to achieve the appropriate staffing levels as well as the right skill mix needed to address the growing health needs of Ugandans. Unfortunately, the health system still remains plagued with high health worker absenteeism rates that affect productivity and denies Ugandans critically needed health services. We must all work to ensure accountability, including addressing absenteeism and improve productivity of the health workforce if we are really going to realize our true sector performance improvements. As partners, we are ready to join the Ministry of Health and the district leadership, including the politicians and the technical teams and various community and non-government stakeholders, to collectively find creative and affordable ways to improve health worker performance. As I wind up, I'd like to once again, on behalf of the health development partners, congratulate the Ministry of Health on holding the 29th Joint Review Mission. We continue to pledge our commitment to support the Ugandan people in improving the health and well-being of Ugandans and achieve the National Development Plan 3 health sector goals. Thank you very much.
Thank you very much, Rose. Ladies and gentlemen, I want to recognize the presence of the Honorable Minister of State, General Duties, Honorable Nipa Kaweya, who has joined us. You are welcome. Thank you. At this juncture, allow me to invite the WHO country representative, Dr. Jonas, to make a statement.
Good morning. Honorable Minister of Health, Honorable Minister of State for Health, Honorable Members of Parliament present, Madam PS, Head of Missions Agencies present here, and development partners, representatives from other ministries, departments, and agencies, representatives of civil societies, NGOs, and implementing partners, DHOs and local government officials, CSOs. I hope all protocols observed, ladies and gentlemen, and our youth. First of all, allow me to associate myself with the statement by the incoming chair of the Health Development Partners, and I also appreciate the presence of my brother, the head of UNICEF, Dr. Munir, and on behalf of WHO and other UN agencies, I would like to congratulate, first of all, Honorable Minister for holding this meeting. It's a great pleasure and an honor for me to give a remark at the 29th Health Sector Joint Review Mission, centered around the theme of leveraging community health approaches and systems as catalytics for strengthening population health and safety in Uganda. The theme serves as a powerful reminder to us all that community health, as advocated under the primary health care approach, remains the most effective route towards achieving Sustainable Development Goal, especially SDG 3, which states that ensuring healthy living and promoting well-being for all at all ages, along with the other health-related SDGs. I would like to say a special congratulations for Ministry of Health and Uganda and all of us here and those who preceded us in the previous 28 joint review missions. It's not easy to sustain such commitment. It's only a few countries I know who were able to maintain joint reviews regularly with such engagement of all stakeholders. It's not a small achievement, and congratulations. I extend my heartfelt congratulations to the Ministry of Health for once again emphasizing the crucial importance of community health. The National Community Health Strategy 2021 to 2026, launched in April last year, stands as a testimony to the government's unwavering commitment to community health. I urge all partners to diligently follow and support this strategy as it provides a clear guidance on delivering quality, affordable, integrated, and equitable community health service in Uganda. We are all familiar with the parish development model through which the Ugandan government aims to deliver socio-economic development services to communities. It is highly recommended that the national community health strategy be anchored on the PDM, ensuring increased access and coverage of integrated and people-centered health service for all Ugandans within the context of sustainable development. Ladies, gentlemen, and the youth among us, in our pursuit of enhancing health service delivery, I urge partners and implementers to prioritize implementing and people-centered community health services. These services should not only address the immediate health concerns, but also focus on the broader determinants of health. Not only health, but the determinants of health, looking into the economical, social determinants which affect our health: alcohol, tobacco, physical exercise, and other issues should come into the dialogue of health. Empowering individuals, families, and communities to manage their health is paramount in meeting the diverse health needs of Ugandans. To strengthen the population's health through community engagement, the government, we urge the government to consider taking several vital actions. One, enhancing current political commitment by promoting health in all policies and ensuring sustainable financing for health system strengthening across all sectoral policies and plans. Second, strengthening community engagement and participation of health sector agenda setting, implementing and reviewing at regional and district level, thereby improving health-seeking behavior and outcomes. Three, strengthening health information and surveillance system at the community level to detect health challenges early, enabling evidence-based response and managing of outbreaks or other challenges. Four, focusing on competency-based pre-service and in-service training provided by public and private institutions. These approaches ensure that health workers trained in Uganda possess the competencies and behaviors necessary to meet Uganda's health and population needs. Ladies and gentlemen, in conclusion, I commend the government of Uganda, in particular the Minister of Health and your staff and leadership for the significant progress made in recent years. As you all know, the 2022 Ugandan Demographic Health Survey findings reflect notable improvement, with under 5 mortality decreasing from 126 to 52 deaths per 1,000 births, infant mortality reducing from 71 to 36 per 1,000, and neonatal mortality decreasing from 27 to 22 per 1,000, all between 2006 and 2022. These are not small achievements. Moreover, maternal health care coverage indicators have seen positive growth, with 95% of antenatal care provided by skilled providers, 91% of births occurring in health facilities, and 91% of births attended by skilled providers in 2022. And we owe it to the good leadership we have seen from you, Honorable Minister, and the Permanent Secretary, and the partnership with development partners, civil societies, and local government. And we should congratulate you for that. These achievements are truly commendable, and I extend my congratulations to the Ministry of Health and all partners who contributed to this success. As the health sector continues to deliberate on strategies and priorities for the coming year, I reaffirm our commitment to partnering with the Ministry of Health and sustaining the progress made in these health sectors by working with all partners included. Together, we can build a resilient health system and ensure healthy lives and well-being for all Ugandans, and ensuring Uganda contributes to the global health and security. Thank you.
Thank you very much, Dr. Jonas. Ladies and gentlemen, we are coming towards the end of this official opening ceremony. And please join me to welcome the Honorable Minister of Health, Dr. Jean Ruth Acheng, as she addresses us and also opens this introduction session.
The Honorable Minister of State for Health, General Duties, Honorable Anifa Kawoya, the Permanent Secretary, Ministry of Health, and the entire team from the Ministry of Health, our health development partners, representatives from other ministries, departments, and agencies, representatives from the local governments, including the chair of local governments, the DHOs, and others, representatives of the private sector, representatives from the civil society organizations, the media, distinguished guests, ladies and gentlemen. DG, allow me to start by complaining and apologizing. First of all, the venue is a difficult place for all of us. And I need to apologize to you. We should have gotten a better venue where we can all listen to each other. Number two, I am wondering why we are living. I would really appeal that after break, we move away from the back and fill these positions, because I know what happens at the back. People are on WhatsApp, mail, and so on, but we are here to discuss serious issues as we listen to the objectives, and we must achieve those objectives. So if you have come with your phone, with your laptop, and you are seated at the back, I know really you to our joint review mission. It is my pleasure and honor to welcome you all to the 29th Annual Health Sector Joint Review Mission. As you are aware, this is an annual event that brings together the health sector players and stakeholders to reflect on our performance, achievements, and challenges in delivering quality health services to the population in Uganda. Our current goal under the NDP 3 is to ensure population health, safety, and management, and this is in line with the Sustainable Development Goal 3, to ensure healthy lives and promote well-being for all at all ages. Ladies and gentlemen, we are here to deliberate more on the overall sector performance over the last financial year, 2022-2023. And a comprehensive report has been prepared. I am sure all of you have copies with you on the tables. I am also glad to mention that in addition to our routine health information system, this year we have been able to capture progress for most of the key result or health impact indicators based on the Uganda Demographic Health Survey 2022 preliminary report, which was disseminated in September and which most of the previous speakers have alluded to. The UDHS 2022 findings show that the country has made remarkable progress in a number of indicators, and this is our effort together as the health sector, as partners, civil society, private sector. So it is not the Ministry of Health, it is all of us together. So you need to congratulate yourself for doing a good job. We have nearly halved the maternal mortality ratio over the last 7 years. Child mortality also reduced by almost a quarter. I'm sure you know the statistics. And neonatal mortality, which had stagnated at 27%, also declined, although by a very small margin, but it declined. This momentum should be sustained because no life should be lost due to preventable causes. I therefore would like to appreciate the NRM government for always including health among the priority sub-programs. The Ministry of Public Service approved the human resource structure for the national and regional hospitals, the specialized facilities, Uganda Heart Institute, Uganda Cancer Institute, general hospitals, health center 4s and 3s. And we hope that when fully implemented, it will address the current human resource gaps in the sector. Our role now is to advocate for increased wage, to fill the vacant posts, and also ensure health worker performance. I heard from all the speakers, and all of them talked about human resources, the limited numbers. But as you're all aware, currently there is a ban on recruitment except on replacement basis. And we all know the reason why. There is no wage, and the country does not have adequate money to pay salaries, which is recurrent. And so our humble appeal is that the people on the ground should put in their best as we wait for the ban to be lifted. And I'm hopeful that it will be in the very near future, perhaps in the next financial year. I am informed that work is ongoing to develop performance indicators for some key cadres. And I have already seen this with the regional referrals and the nationals. This should be expedited and shared. A lot of work has been done to address absenteeism, right from the time of requesting everyone to register, to clock in, and now to use of technology. My humble appeal is that we all become responsible people, because there is no way you can take a horse to the river or to the well or anywhere and force it to drink. It is only when we become committed people and take it upon ourselves to do the right things without waiting to be flogged or to be forced. So even as we are working on these performance indicators and so on, my humble appeal to you is to become passionate about what you do. At the just ended UN General Assembly, as a country, we made our commitments to achieving universal health coverage. I will go through some of the commitments that we made so that you're all aware about what we are supposed to do together as a team. Number one is strengthening community-led interventions through programs that build capacity of the community health workforce. We launched the community health strategy in January this year, and with support from partners, we are piloting the community health extension workers in Mayuge and Lira districts with promising results. These community health workers will support our health promotion, and environmental health staff will also come in to enable us perform better in alignment with the parish development model. I am extremely excited that all the previous speakers have appreciated the direction in which the health sector is moving. And therefore, my humble appeal to all of us is to intensify our community-led interventions by seriously engaging with the communities so that we stop complaining about absence of medicines, but enhance health promotion and disease prevention. When we prevent, we will save resources and channel them in the rightful places. The second commitment, we committed to implementing programs that address the social determinants of health at all levels. For example, water and sanitation, food security, education, safe transport, housing, etc. And WR, I heard you mention this. We are very much aware that without addressing this, we may not achieve universal health coverage. And so again, it is my humble appeal to all of you that this is a very pertinent area for us to look into. Health cannot do it alone. We need a multi-sectoral approach. 3, improving access and quality of health services for the population. As a sector, we are truly grateful to all our partners who have unwaveringly supported us as well in this area. And I am glad I heard from local government the appreciation in infrastructure that the health sector has been addressing. We shall continue to do this, but also we must address the area of availability of health workers. And as the civil society said, they are waiting to see if the salary enhancements will translate into better services. I cannot promise you, but again, that is an area that we must address together. Number 4, increasing investment in health infrastructure, medical products, technology, and digitize health information. I know there is a lot of work that is ongoing to digitize health information, right from the community health information systems through to the health facility information system and to the policymakers. We need this information because it helps a lot in planning. We take note that there has been a lot of challenges with timely delivery of medicines to the health facilities, as well as the inadequate budget for medicines and medical products. Government is committed to increase the budget for the medical products in a phased manner, and this is to the local governments. But the delay in delivering medicines is not entirely a fault of the national medical stores. It is an area that we are still continuing to negotiate on because the systems that we use to access money does not favor timely delivery of medicines. But we'll continue to work on it together with partners so that Ministry of Finance can understand and become flexible with the system that is required for health. Number 5 is building capacity of the health workforce in terms of numbers, skills, and capacity for research and development while addressing motivation and retention. And number 6 is addressing financial risk protection through the introduction of the National Health Insurance Scheme to protect households from catastrophic health expenditure. And I'll be talking about that a little later. So these priorities should be taken into consideration as we plan for the remaining 1 year of the National Development Plan 3, as well as during the development of the National Development. Ladies and gentlemen, allow me now to throw some light on the last commitment regarding the introduction of the National Health Insurance Scheme. And I want to thank all of you for the support that you have rendered to the health sector as we work on this, and also for mentioning it in this 29th Annual Sector Performance Review. As you all know, this is long overdue and has gone through a protracted process of stakeholder consultations to address the various interests. And the interests are not few. They are overwhelming. The draft bill 2023, and take note that I have said the draft bill 2023. And why do I say this? Because many of you will recall that actually last financial year, not last financial year, in the last government, the National Health Insurance Scheme Bill was approved by Parliament. But many of us, and I'm saying many of us because we are many people who are to be consulted, we are not happy with the bill. And so when the bill went to His Excellency the President for his assent, it was returned to the health sector. And we have taken a bit of time, close to 2 years, consulting many of you. So the draft bill is now ready for submission to Cabinet. And I want to reassure you that in the next 1 to 2 weeks, it will be in Cabinet, and hopefully we shall again lay it on table in Parliament. There are a few principles that describe this bill. Number one, the National Health Insurance Scheme enrollment shall be mandatory for all citizens above 18 years, without including indigents and other vulnerable groups. So we shall all be enrolled. When I say mandatory, I'm sure all of you understand the English word. So we shall all enroll. Number two, and this was a very contentious issue that we have labored to address, there will be no employer contribution, as this was perceived as overburdening the private sector employers. So the employers will not contribute. This was an issue raised by the manufacturers, by the unions, by the private sector, by the various organizations. The employers do not want to contribute. And so to avoid stagnation of the national health insurance, they will not contribute. But me and you will contribute. 3, contributions shall be segmented according to income groups to maintain the principle of solidarity and affordability, and not as a percentage of the salary, because the unions rejected the idea of percentages. Rightfully so. However, allow me to say here that while the indigents will be contributing once a year, the rest of us will be contributing monthly. A small fee, so that we maintain the principle of solidarity and affordability. So with those few highlights, if you want to understand more about the National Health Insurance Scheme Bill, Dr. Sarah Vyachika is there. You can engage with her over break time, or you can engage with me as well, and with the rest of us, we shall be able to explain more. But what we require from you is support. Currently, in the entire East African region and beyond, it is only Uganda that does not have an insurance scheme bill. So we need your support so that we can mobilize more resources for the health sector. Because if we are supposed to improve, or if we are to improve, we need the grease that oils the wheels, and that is the money. And you heard very clearly, especially from the health development partners, that we are not yet putting adequate money into the health sector. I'm not sure whether we shall reach the Abuja Declaration. I'm not sure, but maybe in future. Ladies and gentlemen, the theme for this year's joint review that all of you are aware about is leveraging community health approaches and systems as catalysts for strengthening population health and safety in Uganda. Allow me to recognize and appreciate our keynote speaker, Professor Stefan Swatling Peterson, in charge of Global Transformation for Health at Karolinska Institute and affiliated to Makerere University School of Public Health, for accepting to undertake this role of the keynote address at this joint review mission. Professor, you're welcome. I wish in a special way to thank our development partners, the private sector, civil society organizations, other ministries, departments, and agencies, and all the health workers for the commitment and contribution made to the sector achievements. There are still gaps, and where there are gaps, I request that we embrace them, jointly analyze them, and develop joint action plans, as is the objective, one of the objectives in this joint review mission. I cannot end without appreciating all those who participated in compiling the annual health sector performance report, which will be the basis for discussions over the 2 days. We need to appreciate them. It is not a small job. Thank you very much, Sarah and your team. We are glad that we have the documents with us. Please take time, even after the DG has taken us through, to look into the details. Allow me also to appreciate all the technical working groups through the planning department for your contributions. Many partners, including HIPAC members, have supported and participated in various activities leading to this review, and we appreciate you. Allow me to mention also a few partners, a few to represent the others: WHO, UNICEF, USAID, Uganda Health System Strengthening Activity, USAID, Uganda Health Activity, the Embassy of Ireland and Embassy of Netherlands through UNFPA. Thank you for your technical and financial support. Lastly, once again, I welcome you all and wish you fruitful and candid deliberations at this 29th Health Sector Joint Review Mission for God and my country.
Thank you very much, Honorable Minister, and I want to believe we have declared the meeting open. So I want to request
sometimes we forget, but since you have brought me back to the podium, allow me to just mention one thing before I declare, and that is the issue of ambulances and vehicles that was raised by the chair of Olga. Our chair, the health sector and partners would like to appreciate the local governments for what you are doing. But we have pain on two areas. One is the issue of the vehicles, and two is the issue of accountability for resources. In regards to the vehicles, we are watching with pain the mishandling of the COVID-19 pickups. All of us have been seeing on social media and other places, and I know the PS and the team have been trying to make efforts to ensure that these vehicles are put for the intended use. Our appeal to you is to take back our voice, that what we are seeing is not good, and in future, you run the risk of not receiving vehicles. Number two is about the ambulances. You have received guidelines for use of ambulances. The health sector does not have all the resources to run the ambulances. We also expect contributions from the local governments. However, our appeal is also that the ambulances are used for where they are intended to be and not for other uses like we have seen. We want to appreciate our partners who are very committed to ensure that all constituencies, and I want you to mark the word constituencies because the National Ambulance Policy stipulates that ambulances are given per constituency, not per health facility. So we are working with partners and want to appreciate partners for supporting us with 116 ambulances. We shall be distributing them shortly, but again with a heavy heart. Shortly, but with a heavy heart, because we are all watching the misuse of these vehicles. So take back our voices that while the Ministry of Health and partners are doing their best, we are not seeing good care of these vehicles. The second one is about accountability for resources, and I'm sure you heard it very clearly from the chair of the Health Development Partners. We are struggling to receive accountability from local governments, which take years, and partners cannot wait for years for accountability. There are resources from WHO, UNICEF, Gavi, Global Fund, and so on and so forth that are not accounted for. That is an area where there is no negotiation. When you don't account, we shall not receive resources, and the accounts that we have with these partners to support us will be closed. Although I didn't want to say it earlier, but as the DG asked me to come back, I thought I needed to say it because the concerned people are here in this room. So we appeal to you to save us the embarrassments of funds being cut and account for resources that the local government. So it is now my honor and pleasure to declare the 29th Health Sector Joint Review Mission officially opened for God and my country.
Thank you very much, Honorable Minister. I think at this juncture, I want to invite you back to your seats. Come and join us again at this level. And I want to consult. May I consult? I'm already being pushed here by some members of the opposition. You know, this is democracy. We have to all agree together. Honorable Minister, come resume your seats. There are two proposals that we get the keynote address at this point. There's also a proposal that we break for tea and get the keynote address after. So what do we have? So what is the guidance? The teas have it. So we go for tea. We go for tea, but we have to keep time because we are much behind schedule. So it is a quarter to midday. We come back at Can we pick our tea and come back by midday? You can pick your tea and come with it. Quarter past. Okay, let's make it a quarter past, but strictly a quarter past. At a quarter past, we shall close the doors. Those who are not inside will not come in. So, where is the tea? Okay, guide us.
Thank you very much. The tea and coffee is downstairs, unfortunately.
The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. Vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Loving when you stir it up, that body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why.
Hello. Welcome back. Welcome back from the coffee break. We have done very well. We have been able to manage the coffee within time. So may I request that so that we get ready for the next session. Remember, we have encroached on the after break time. So that means that our lunch will be delayed, and we wouldn't like to delay it any further. Thank you for keeping time. Just settle down. As the DG finds for us the next chair for the next session. Officially in the program, the chair for the next session is the Minister of State for Health, Primary PHC. But DG is guiding that we are still on the first session. So that means that the DG continues to chair the first session. But at some point in this after break session, the DG will be presenting the overview of the report. So at that moment, still the DG, you need to find a chairperson when you are presenting the report. Otherwise, if you agree, you guide us accordingly. I think the members are ready. We have the Honorable Minister of Health, State for General Duties around. And we have our keynote speaker, very, very ready. And he has taken coffee. He's ready to fire. So, Director General, over to you to guide, to mobilize the other senior top members, and we start. Thank you very much for keeping time. Otherwise, Dr. Stefan, you can take your seat. Take your seat. And as we wait for the Honorable Minister and the other members of senior top to come in. Once again, the places of convenience, the restrooms are just at the back of this hall. You don't have to go out. A few people have failed to locate them, but just at the back, on your left and on your right, there are places of convenience. Once again, we apologize for the venue, but I think the minister sought your indulgence on that. Bear with the exercise and for your health. So we should start anytime now.
Come in front. Meanwhile, the people seated behind, please come closer in front. There are seats in front. As guided by the minister earlier, we don't know why you prefer to sit behind when there are seats in front. So please come in front. The minister is entering in a minute. Because of the importance of this keynote address, we thought that we should wait for the minister and PS so as to start. But as the minister comes, since the minister knows Peterson very well, I can meanwhile introduce Dr. Stefan. Stefan is a medical doctor from Uppsala University. Also holds a Masters of Public Health from Harvard University and a PhD from Uppsala University again. He specializes a lot in institutional development and public health with special interest in child health. Many of you who have been around will remember him. He's based in, he's a professor of public health in Karolinska University, but he had quite a lot of work here with Makerere University before he moved to New York, UNICEF, as the chief of health at New York UNICEF office, but is now back to Karolinska University in the Department of Global Transformation for Health, and is also a visiting professor to Makerere University, again, School of Public Health. So he has been invited to make a presentation on the theme of this again. Community health system in Uganda, improving transformation of community health systems in Uganda, emerging opportunities for the newborn survival. So ladies and gentlemen, join me to welcome Professor Peterson, Stefan, to make a presentation as our keynote speaker.
Thank you very much. Honorable Ministers, PS, DG, my friend Henry Mwebeza, and Excellencies, ladies and gentlemen, all protocol observed. It's great to be back here after 25 years, because that's how long I've been a student of Uganda. I showed up here in 1998 to work on integrated management of childhood illnesses at the Ministry of Health in Entebbe, and I was received by a certain Dr. Jessica Nsungwa, who was actually spearheading that development at the time. And I've never quite left you in spirit, and now I'm back to live for the third time here. Uganda in many ways has propelled me also all the way to New York, as you said, and being Chief of Health for UNICEF globally. So as I've just returned now, I thought I would take the liberty with your title of actually looking at Uganda, but also mixing in some of my global experiences, and you'll correct me where I go wrong. Thank you. So, I also butchered the title. I said health systems and systems for health, and a 25-year perspective on that. Because when I showed up in 1998, your predecessor, Henry, was the inspiring Professor Francis Omaswa, who was DG at the time. And he famously said, health is made at home and hospitals are for repairs. And thus I brought a picture of my home and where my health came from, because health is a multi-sectoral construct. This is me at 1 year of age. I don't know if you can see the resemblance or whatever. Right? But you know, for 25 years that statement has stayed with me, and I think we heard the WHO representative also make reference to actually the determinants of health being outside the health sector. I think it was also very timely coming back here that there was a demographic and health survey report out so I could read up on developments. And I also saw that the 25-year observation period I had is actually contained in this graph here. And Jessica, as I call Dr. Nsungwa affectionately, and me, we were roaming around in 56 districts at the time, worrying about malaria, pneumonia, diarrhea, instituting something called home-based management of fever, which became ICCM, Integrated Community Case Management, which spread from here actually across Africa and big parts of Asia, etc. And I think actually plucking some of those lower hanging fruits, I would say, also with the help of community health workers in the many names they have had in Uganda and are still having, has been some of the lower fruits, hanging fruits that have actually allowed this tremendous progress we see up today, where the under 5 mortality rate is at a third of what it was in the time. But I also wanted to actually pick this opportunity to alert you to the newborn mortality, the neonatal mortality, the first 28 days in life, which way back in the year 2000 was 33 out of 151. That is 20% of the total mortality. But as we've been plucking the lower hanging fruits, if you look to the right, 22 out of 52, if you remember your high school mathematics, that is something like 40%. And that is a trend across the world, that as we actually take care of the relatively older mortality causes, the malaria, pneumonia, diarrhea, the bed nets, the community health workers distributing drugs, and what have you not, we remain with the harder, higher hanging fruits that hang inside a functioning health system. Because the quality delivery and newborn care is much more complex, isn't it, with due respect. In addition, is that if you look at recent Lancet studies, your stillbirth rate is 21 compared to the newborn mortality rate of 22. And we all know in this room that a lot of these so-called stillbirths could have been live births, and many of them died during delivery. So in fact, I would like to say that the problem is bigger than the 22, if we're honest about it, and if we stopped misclassifying stillbirths. Nevertheless, this is a tremendous achievement that I would never have dreamt about 25 years ago, so congratulations and hat off. But I also want to say that how we got here is not necessarily the way forward, because the fruits get harder and harder to pick, right? As it were, as we move forward. And if we then look at the mortality trends and the targets for 2030 under the SDGs, and we focus now on the newborn mortality rate, it's now at 22, plus the stillbirths, if you will, or some of them, and you're headed for 12, which is the target under the Every Newborn Action Plan taken in WHO Assembly, etc. And that means you've been progressing now at an annual rate of reduction of 2.7%, and you need to double that to actually reach that target. So you need to move faster than most of historical trajectories of other countries. And in fact, you need to move twice as fast in the remaining 7 years to reach that target. So it's time to pull up our socks and whatever we pull up and actually increase the speed and do better. Now, and I'll try to address and speculate on some of those issues. But yes, we need to maintain the gains, and then we need to pick higher hanging fruits, and we need to do it faster. So this is a tremendous challenge I'm giving to you in this room today to do that, and to all of us. The other thing I could never have imagined way back in the year 2000 was that facility delivery would go up to 91%. So I think that's another tremendous achievement. Congratulations on that one. So I'd like to say, and as you know, as we've reached there, maternal mortality has halved, but it's still at 189. And again, the SDG target is, can we have a quiz? I'm a professor. 70. So again, you have a tremendous feat of actually more than doubling it again, and more than halving it again in the 7 years that remain. We've already discussed the newborn targets. The good thing with this is that you now have the people. We have the people in the facilities. So what we need to add now is the quality of the care, what's happening in the facilities, right? And I think that's a tremendous achievement in itself. Now, again, with the focus on newborn, what is it we can and should be doing, though? So my friend Joy Lawn, born in Uganda, and I'm sure you've all heard her speak many times, she distinguishes a couple of phases. She says when newborn mortality is at 45 up there, then it's hygiene and hand washing and going to antenatal care and simple things that can actually make a big difference. And obviously community agents have a lot to do there. Then as you dip below 45 to 30, then you're looking at improving the pregnancy and newborn care, antenatal care, etc., and you can cut another 50% off. But where you're going now is actually the need to seriously improve the quality of maternal care and of newborn care, and starting to build newborn care units, special newborn care units at district level. And I think you're targeting 25 now. And then eventually, as in my country, Sweden, it's the highly specialized supportive care if you want to get down to 5 or something like that. But to reach 12, it's now the newborn intensive care units, the specialized care units at district level, etc. And if we look, and I had the opportunity to visit, for instance, India and Bangladesh in my UNICEF job, where they are now building one such unit per district across those big countries, and they're making very rapid progress in reducing newborn mortality. Yes, you need kangaroo mother care, but that is on top of having one of those units as well at district level. But we can go closer. We can go to Tanzania. Tanzania, with a whopping 147 districts, unless I'm wrong, are now targeting to build these units in 80% of their districts within 2 years. They're now adding 2.5% to their total health expenditure, and the president herself is spearheading the fundraising. I understand that they've raised $30 million now in the last 6 months. So Tanzania is on the move to really do this and build these units at that district level, where I think you're targeting 25 now, but that's one of the challenges and accelerations to support the kangaroo mother care at that level. We do know very well what to do now. And this thing that is flashing on the right, the newborn toolkit, it actually tells you everything you need to know. The tools, the equipment, where to buy it, how to train your biomedical engineers, how even New York, during COVID days, we spent a lot of energy trying to get oxygen out for COVID. But as you know, oxygen is an essential commodity that needs to be present everywhere. And there's a big job going on here and elsewhere to make that happen. So congratulations on that. However, to implement all these tools, etc., you need to have your health system in order. And that's why we're on the left there with the usual health system building blocks, right? We've already discussed the human resources this morning, and I congratulate you again on raising the numbers, if not yet the number, to get them. And obviously, to manage these small, sick newborns, or even a small newborn, you also need to add the skills and competencies. So, yes, numbers of people, but also the skills and competencies. I remember vividly visiting in northern Ghana, one of these newborn care units, and meeting the medical superintendent. And I asked him, congratulations on your newborn care unit. How many staff does it take for you to man it 24/7? And he said 24, 3 shifts of 8 people. So obviously these are very resource demanding additions to our health system and health services we're putting in there. then wanted to direct my attention a little bit to the leadership and governance. My days in the Ministry of Health here, 98 to 2000, we were discussing sector-wide approaches and one plan and one budget, etc. My impression in the 2 months I've now been back, since I moved back here again, is that now it seems to be that districts now have partners or they don't have partners, and you're in a difficult situation that we heard alluded to this morning of actually not having that one plan and one budget. So I hope that is one of the challenges you will address in this meeting here. As I came down Salama Road to reach here in the morning, I saw the building of a new hospital. But infrastructure-wise, I don't know. How much infrastructure are you adding across your districts? Because certainly, since I was here last, you have more people, isn't it? And that typically requires more infrastructure. But I saved the best for the last here, the financing piece, where we've heard alluded to what's happening and the plans here from the minister. But I actually went to the World Bank yesterday to look at the per capita health spending in Uganda over the last 25 years again. And as you can see, there's been a slump with the per capita health expenditure going down over the last couple of years, and which is the top per capita spending is the top line, and the bottom one is the percent of gross domestic product. And I would like to propose that it's not just COVID and the recession of COVID, but it's also numbers defeating you, as in population growth. Because compared to when I lived here last, you now have double the population, isn't it? And you double every 20 years. And when we're here 20 years from now, you will have doubled again. And that those numbers are actually posing a serious challenge to you achieving the goals and the targets you're setting yourself. It also affects the aspirations to become a middle-income country. The real gross domestic product growth, after you've deducted population growth, has been 1% over the last couple of years, partly explained by, of course, climate catastrophe, COVID, etc., but also by population growth. And I think it's quite intuitive, again, if we remember mathematics. It's about nominators and denominators. And if your economic nominator grows by 3%, but meanwhile the denominator, the population, grows by 3%, you're equally poor, isn't it? And so again, it comes back to division and high school mathematics. To me, it's urgent to reduce the denominator there to achieve these targets. Half of Uganda's population is less than 15, right? Under the lower black line here, which is an expanding, and you truly have a population pyramid, right? This is a tremendous resource, potentially, because 4 out of 5 continents in the world now have aging populations and 2-child families, or less. And as we get old in Europe, in Asia, and in other places, who is going to be the world's labor force? And I think you're familiar with the concept, the demographic dividend, which is when a majority of your population is working age, say between 15 and 65, between the 2 black lines here in this figure. And half of your population is not, right? Half of your population needs schools, needs immunization services, need delivery services. But you have a tremendous potential in these young people to actually bring them up healthy, to bring them up educated, and to give them jobs. And that's what they're asking for. And one country which did this very well is South Korea. I think many of us had admired the economic growth of South Korea. And the demographic dividend looks like the figure on the right. It's thickest on the middle, isn't it? This was South Korea in the year 2005, when they were in the midst of this. And the majority of their population were between the 2 black lines, between 15 and 65, and they were productive labor force, right? There were relatively few old people to pay for, and there were fewer young people that needed new schools and new investment and new jobs and all of those things that you battle with. So the key to this is, of course, to reduce the fertility rate in order to have economic growth, to have better health, to realize the demographic dividend, or whatever you want to achieve for your population and for Uganda. So returning then to the demographic and health survey, may I direct your attention to the thing on the extreme right. The percent of demand for contraception met by modern methods is 60%, which is of course 60% is more than half, but it also means that there is 40% unmet need, isn't it? If you remember mathematics again. 40% unmet need, and that's one of the extremely low-hanging fruits, I would say, to change things for the country at large, but also for newborn outcomes, isn't it? Because fewer births, and particularly fewer births in young girls, 1/5 of your births is children giving birth to children, adolescent birth. And what can you do to actually drastically reduce adolescent pregnancy and unwanted pregnancy? Contraception is one of them, staying in school is another one, etc. Demographic dividend requires human capital. And human capital is not a product of the health sector alone or of health services. It's a multi-sectoral product, isn't it? To produce an 18-year-old, healthy, educated, integrated young person who can join the labor force for Uganda and over time for the world, as the rest of us will be in our 80s across the world. Now, again, looking at the World Bank page here, it paints a bit of a bleak picture and gives us a big challenge in this room for this multi-sectoral challenge. One, it says that children here are likely to be 38% as productive as they could be if they had proper full education and full health, if they realized their full potential for various shortcomings that this meeting and others in the education sector, etc., will address. The third bullet also talks about school dropouts, right? That, in fact, as you start at 4 years of age, you're expected here, statistically, to complete 6.8 years of school by the age of 18, while across sub-Saharan Africa, kids complete 8.3. So the educational capital, as it were, here of East Africa, Uganda, seems to have a huge dropout problem. And my fourth bullet here, though, is a quality issue, what is referred to as the learning crisis, where, again, the World Bank says that while they may spend 4.3 years in school due to low quality, effectively that equates to 2.5. Now, you're not alone as Uganda in these challenges. Across the world, now 70% of 10-year-olds don't know how to understand a simple text if they read it. I'll restate that. The learning crisis in recent UNICEF UNESCO report, 70% of 10-year-olds can't understand a simple text when they read it. And that's referred to as the learning crisis, and unfortunately you share it. And in summary, this impedes sort of children reaching their potential. Uganda getting the full human capital of what you could be getting. Now, the context of where children are growing up is also changing. This is now the world's population, and 55% of the world's population is now urbanized, and in the next 20 years, 70% of us will be urbanized. And that means that children are no longer necessarily growing up in those villages where I grew up, and maybe some of you grew up. They are growing up on the perimeter of the Kampalas of this world, without urban planning, without a park, without a pavement to walk on necessarily, and in the food environment here, where there is mandasi and soft drinks, and you know what it's like, right? The other element, I know Uganda's urbanization rate is about 27% now, so you're a bit late, but I think you're catching up. The way I see Kampala growing in my absence here, and the number of boda bodas growing, I can see that this is happening here as well. In the urban setting, as in the rural, we also now are no longer in exclusively public delivery systems, not for health, not for education. They are mixed delivery systems. I'm sure your kids are in private schools in many cases, right? And many people go to private health services. And private health services come in many guises, right? The not-for-profits, the for-profits, the social enterprise, community health workers, whatever they are called, the healthy entrepreneurs, the living goods, and all of those, right? So there are many guises, and the famous drug shop, right? There is a lot of resources going there. Again, World Bank says that 37% of the health spending in Uganda is private, out of pocket. And my question and challenge to you, what's the value for that money as we're looking for more money? And how can we harness those providers to get better value for money from there? So I then wanted to return to Professor Omaswa's statement and actually rephrase it a little bit. Health is made at home, hospitals are for repairs, is what he said 25 years ago. I'd like to say that health is made in homes and communities across sectors, not necessarily just the health sector, and requires maintenance and repairs by the health sector in its many forms. So again, health is made in homes and communities across sectors and requires maintenance and repairs by the health sector in its many forms. And as I salute you for the National Community Health Strategy, I think with regards returning to the newborn here, there are a couple of things you can hope for at that level to prevent and promote health. One of them being the unwanted and the adolescent pregnancies. 1 birth in 5 in Uganda is a child giving birth to a child. A girl less than 18 having a child. And to me, that is completely unnecessary and it's wasted human potential. There are also other unwanted pregnancies that can be addressed by meeting the unmet need. It's not just a question about surviving, though, much as we talk about mortality. It's about thriving as well and supporting early brain development even before you start school, and then keeping girls and boys in schools. I know you had a huge COVID dropout and many of them didn't return, but keeping them in school is not enough. Talking to the education colleagues, and I understand the Ministry of Health is now together with Ministry of Education and Gender and actually promoting learning in schools. It's not just a question about going to school, it's a question about learning in school and how can that happen? And what are the life skills you learn also with regards to health, etc. And then looking at the urban environment particularly and the commercial pressures and the nutrition transition Uganda is under, I would like to say that you need to promote good diets. Yes, for the stunting, but also for the overweight and the obesity, which is coming in many places. The food environment, if you look around where people grow up, that is not necessarily nice, right? And if you're like me, I eat the food that is around me and that is put in front of me, and not the one that I'm supposed to be eating necessarily, right? And what is coming around the corner is the diabetes explosion. Type 2 diabetes in my country, Sweden, has a 5% prevalence. Last time I checked in Uganda, it was 10%. I don't know if that's still correct. But in India, it's 20%. So you guys can double again. And I think you will, unless you look out. And just as you very successfully nipped the tobacco epidemic in the bud through legislation, I think you should nip this commercialization and food transition in the bud and prevent this diabetes epidemic from really washing out health services from you. I would like to say, however, God, this thing wants me to stop. That being in the community is fine, but we also need quality care in health facilities to realize the goals. I've already alluded to the health system building blocks, or however we want to divide the health sector, and particularly the importance of financing to actually support the delivery of these services and quality services that we want. And I think, given how complex your health service delivery has been now, decentralized services and the mixed provision systems, there's an element, I think, DG, for you to return to your quality roots here. There's quality control, but there's quality improvement, working with all of these various actors, I would say, and across district. But finally, and maybe my most important message is in yellow down there. I think we are on the supply side. We are constructing and offering health services. But what are we doing to strengthen the demand side? The ordinary citizens and the patients. We've heard accountability mentioned many times this morning. Some of it can be financial, but other accountability is social accountability. Are the services that I'm receiving good or not? Am I being treated fairly or not? And if I'm the poor peasant Mukasa, who am I to challenge the doctor or the nurse? We need innovation in this space for people to actually to share their experiences, their services, and make this the matter of civil society, make this an argument for debate in the district councils, not the least by the opposition candidates, and asking this district secretary for health, why are we having this report? Why is our data here? Without Mukasa having to stick his neck out and challenging. I think there's innovation to be done on that front. And finally, I would like to recommend as a professor that you download and read this report. You'll find it on the web. Systems for Health, everyone has a role. And it actually makes the argument that health systems are fine, but health services don't necessarily build health. Health is a multi-sectoral construct, and we need to enlist our friends in education, in food, in city planning, water and sanitation engineers, and what have you not. And we build systems for health to actually prevent NCD epidemic, as well as managing the infectious disease and injury epidemics we're already having. So this is my recommended reading, sir, and thank you very much for having me back and putting up with me.
Thank you very much, Professor. I think it deserves another very, very big clap. Good. According to the program, I don't see their discussion. I don't see their clarifications or questions. But as I said, as a very democratic country, I can always be guided if we can allow 1 or 2 minutes of questions or clarification, if Professor is okay with that. Good. Now, since I'm taking only 5 questions, so it's first come, first served. Yes, sir. Who is going to help me? With the mic. Peter, you have to talk to Mr. Munir, Dr. Munir, UNICEF country representative.
Thank you very much, and thank you, Professor Stephen, for this very, I would say, thought-provoking presentation. Actually, it's not a question, but maybe a proposal of how to take things forward after listening to the, the presentations from the earlier part of the session and the presentation by Professor Stephen. I think we have probably 3 things that probably low-hanging fruits. Uganda has done a lot in terms of reducing maternal mortality, child mortality in aggregate, with little financial resources and with limited absorption capacity of the funds available. And I think Uganda definitely can do more by increasing the budget allocation and by increasing the absorption capacity. And I would like to suggest the following: if it would be possible to come up with a plan by the Ministry of Health together with the Ministry of Local Government to see different ways of increasing the absorption capacity at the district level. Because it's a real bottleneck, as the Honorable Minister mentioned, that a lot of the donor funding and the government funding is not being spent timely, accountability is low because of bottlenecks specifically at the subnational level. So I would suggest a plan that the Ministry of Health can develop together with the Ministry of Finance and the Ministry of Local Government to increase the absorption capacity at the district level. And I assure you, at least from UNICEF side, and I'm quite sure, although I don't want to speak for the others, we are happy to support that. The second thing is a campaign to convince the pen holders when it comes to resource allocation that more money in health means actually better GDP for Uganda. And we hope that also another plan can be developed and we can convince the pen holders that at the moment Uganda is spending about 50% of the recommended kind of global per capita, not global per capita, the global, the regional allocation of health as a percentage of the national annual budget. It is 7.5% at the moment, while the recommendation is 15%. So I think if the Ministry of Health can take the lead in developing plans for these two things, we will be more than happy to support. The final point is also, I'm happy that now Uganda is moving more into the program kind of center budget rather than sectorial vertical budget. And this is very clear from the presentation from Dr. Stephen, is that you need a multi-sectorial approach, especially when we talk about, child health. It's not only the health, it's the health combined with education, combined with the other social services that are needed in order to change the health indicators. So I hope we can all work together to make maximum utilization of the new budget approach in Uganda, moving more towards a program budget rather than a sector budget. Thank you.
Thank you. Any other comment? Dr. Kabanda.
Thank you, Professor, for such an insightful presentation. You have given us a very good preamble with some historical perspectives and where the country has come from. My request is that it would be in our interest if you could unpack the how, because your presentation, my perspective, gave out 5 core key components which would leverage on as we try to strengthen community health systems. Just to give an example, if you look at the country's young population, which should be one of the areas of focus for us as we do planning and implementation, basing on your experience from other countries and your academic initiatives, what would be the approaches that you'd recommend for us to strengthen the 5 core components, given the historical perspectives of the country, with the focus on the young people, the component of urbanization, social determinants of health, good nutrition, and the component of strengthening social accountability mechanisms? These may have been known to us as the sector, as areas of focus, but the question is, what are your core technical recommendations on how we can be able to focus on these with a number of justifications that can enable us to be able to plan and implement better? Over.
Go back. Yes, behind. Hello. Kindly introduce yourself and your question.
Thank you very much. I'm Dr. Sekaja. Thank you for the presentation. I would like to have an idea about the potential role of traditional medicine in community health strengthening.
Thank you. Dr. Sekaja, I wish you had told us also where you are from.
I'm from Prometra, Uganda.
Okay. Yes. Peter, come here.
Thank you, Professor, for your presentation. It was really touching. I want...
Kindly introduce yourself.
Dr. Bat Amon Decho Karenga. I've observed with concern particularly on this annual health report, and when I looked on the research sector, I realized it was not funded. And now that God has brought our professor here, is there a way you can see how we can be able to publish our data at the district level? Because we have a lot of data in the districts, but we are unable to fine-tune it to produce a researchable document. I would wish that you see how we can engage us and be able to produce such a researchable document. Thank you.
Okay, I think now I can come in front. The PS and then followed by the minister.
Thank you, Professor. I like Yola's statement on social accountability, and this is what really we are focusing on, to make sure that we get feedback from the population and to how they view our services. And that's why we have come up with the client charter, and now we want to see how the health facilities embrace the culture of doing client satisfaction assessment, not full-scale survey, but you know, to do it regularly in our facilities. I want also to mention something on unabsorbed funds. Unabsorbed funds largely, for example, I just want to give an example. This year, we have not started recruitment because they put the ban on the recruitment until that ban is lifted. And what happens? The money that is provided remains unused, and we cannot use that money for wage for something else. And that's largely the money that facilities are not able to absorb, or hospitals, is largely because of that lengthy procedures of recruitment. We have been talking about changing the cycle of recruitment. The procedures, approvals are done before July, so that by July, the people who are supposed to be recruited are recruited, so that we are able to utilize the resources. That is where the challenge is, and I hope that in our meeting today, we'll be able to discuss ably those procedures that delay the recruitment, and then we end up getting money sent back. And that's really, we hope that if we are to address that issue of non-absorbed money, it is about recruitment, and we need to discuss this in detail, how we can change the cycle to make sure that we synchronize the beginning of the financial year when actually people are recruited already, so that then we are able to absorb the funding. Lastly, is also on the statistics. Okay, the World Bank quotes you are putting there on education. I think for me, I got lost a little bit. I did not understand that those figures. I would love to understand a little bit of that, because I remained confused a bit. Thank you very much.
Mine is probably the last one, Professor. I am a little bit disturbed. Your slide on Uganda's very low human capital. We all know that for a nation to develop, one of the most important sectors are education and health. When you get it right with human capital, then you are on the track to development. In your slide, you indicated, and I don't know the source of the info, in any case, and boring the teachers, because we are not learning useful things. If we are learning things concerning Uganda, this is Uganda. These are the sources of things that would make your economy grow. This is what you need to do. You need to have the skills, you need to have the knowledge. But we are learning about Canadian prairies, we are learning about South African histories, Shaka Zulu, and so on. Those are also contributory to some of our challenges. Number two, our cultures, maybe the social structure would also contribute. Now my question to you is, there are lots of the girl child in school to the disadvantage of the boy child. We need also the boy child in school, but also knowing that so many partners came into the country and they focus on what they think is right for us, not what we believe is actually right for us. Thank you.
Thank you. That's a load of good challenges and questions, some of which are comments. Now, Minister, you remind me when I visited Jamaica for UNICEF, and they took me to that in my medical training in Sweden, I never learned as many outgrowths on the bones as these poor girls, adolescent mothers, were having to learn in that Jamaican British tradition school. So I said, my God, what is this curriculum? Is it teaching the life skills we need? And I would say, not just to Uganda, but also to my own country, that I'm not sure that my own children, having gone through good public schools in Sweden, necessarily get the life skills to look after themselves and their mental health and well-being. We teach a lot of other things. So I can only fully support you on the curriculum reform. And as we do that, I think we still need to remember that unless you can read and unless you can do basic mathematics, then we're really in dire straits, irrespective of what you learn on top of that, because those are the foundations. And securing that is key. I'm not an education specialist, but I was tempted more and more to think about human development now, or we can call it human capital. And going back to the determinants of that, to previous questions here. My mentor, Hans Rosling, he famously used to say, you need 5 things to grow up healthy and integrated. You need food, nutritious food. You need clean air and water. You need security, physical and social security. You need good education. And you need a bit of health care. But health care is on the small finger. And so it's food, water, air, physical and social security, and good education, and healthcare. And to me, those are the core things of what all children should be getting. So I don't have the answer to the challenging questions here. But to me, if we can define the co-coverage of core services across sectors, across programs that every child should have, then we should be in a position to monitor that and actually correct course when children are not getting that. Then the other only, but actually being pragmatic. Because if you're in an expanding city environment, there might not be a health center, there might not be a school, you can subcontract that to someone. to actually do that. And I understand that the KCC is doing that now, putting up private service delivery where they need a point, etc. So the same would go for traditional medicine. It needs to be evaluated, I think. If it contributes, fine. If it doesn't contribute, no. And particularly maybe in the mental health space. But I stand to be corrected. You are the experts on your situation. But having been trained as a researcher, I think it needs to be evaluatable. If you're not up to evaluating what it achieves, then I think we should drop it and not be dogmatic about it. And I'm tempted to quote Chairman Mao, who once said, apparently, I don't care if the cat is black or white, as long as it eats mice. And so if it works, whether it's public, private, traditional, let's fix the airplane when we're flying it. Don't wait for the crash endline evaluation. Because as you know, we often run a program for 5 years, and then we have an endline evaluation which says this didn't do anything. Yet if we had embedded a bit of research, implementation research in the programming, we could have done course corrections. This is something that I think is a challenge to implementer side as well as to academics. Because I saw Professor Kadja here. I don't think we in Makerere are necessarily very good at doing that useful research also. So the question is, where do we meet between program people and research people to actually support people like you to analyze your data? I have proposed to Africa CDC, actually, incidentally that you mentioned it, that we should set up a regional network of excellence whereby someone like you could have a mentor in a Makerere or in a Kinshasa School of Public Health or something to actually help you do something with your data or work on your issues. So that was something I would love to pursue, a fellowship somehow to develop the analytical skills of program implementers. DG, I haven't done justice to all the good questions, but then you are the experts. I'm just from very far away. Thank you.
I think a much bigger clap than that, please, for Professor. Thank you very much, Professor Stefan. We really appreciate, and I think it will stimulate the discussion. Actually, it makes the subsequent presentations even much easier. Thank you very much, ladies and gentlemen. I wish to hand over my chairmanship at this stage to the PS, who will chair the next session. Thank you. I was waiting. I was wondering whether I didn't deserve a clap.
Okay, so I want to thank you so much. We are going into the next session. And at this time, I want to introduce to you the Commissioner, Planning and Finance and Policy, who is going to take us through the progress in implementation of the 28th GRM Aid Memoir. Sarah Biachika, over to you.
Thank you, Chair. Good afternoon. Honorable Ministers, the Permanent Secretary, all protocol observed. You recall very well that last year we ended the GRM with a number of action points. And I'm quickly going to go through these action points and the progress that we have made so far. Done? Okay, thank you. So one of the key areas or action areas was on the infection prevention and control practices across all health facilities, and after the JR and Regional Referral Hospital directors, to functionalize the IPC committees. And as of now, a number of facilities have IPC committees. The Health Department is supporting these facilities in terms of follow-up. And we are glad to report that they have come up with an assessment tool and a scorecard. The first round of assessment was conducted in about 6,000, they mentioned about 3,000 facilities, and the second round is ongoing, showing improvement in various aspects of infection prevention and control. A strategic plan is under development for IPC and due for approval, and also revision of our 2013 guidelines is ongoing. We expect that within this year, these documents should be ready to guide our health facilities. We also identified inadequate funding for health promotion and preventive services as a gap. As of now, an investment case has been developed for the community health and a model of financing to community health interventions is also under development. So we expect that these two documents will support us in terms of mapping resources as well as advocacy for additional resources. We also realized that there was suboptimal awareness and engagement of on public health challenges. And here the Health Promotion and Education Department developed a national health education and awareness calendar, which was disseminated to all local governments and partners, highlighting the key messages to focus on within a specified period of time. I'm sure it is also available on the Ministry of Health website. So at any one time, we know that this month our focus will be on malaria, and we expect that all local governments and other partners follow that kind of schedule so that we speak the same language. A number of engagements have also been undertaken with various stakeholders, including radio messages. We deliberated on the inadequacy of blood supply, and here the blood, one of the interventions was to focus on completion of the 3 regional blood banks that are under construction. On average, the 3 blood banks are at about 90% completion. That is one in Soroti, and, which was supported through the COVID-19 fund, and the one in Arua and Hoima are being supported through the UGIFT funding. And we expect that during this financial year, we should be able to equip them, but also mobilize resources for the human resource to manage these blood banks. The blood transfusion services also conducted a number of blood donation drives across the country with many partners, especially the private sector, as listed there, and the outcomes were good in that they were able to mobilize additional units of blood beyond the conventional or routine methods they are using. One of the outstanding areas that we have not yet adequately addressed is equipping and accreditation of health center force that do not provide blood transfusion services. We have a couple of them, both in the public sector, but also in the private sector, that need funding to be able to establish blood storage facilities, but also have power backup, because it's a condition really in order to ensure that the blood does not go bad. We also deliberated on the high rate of road traffic injuries and their consequences on the health service delivery. So a multi-sectoral coordination meeting was held with various stakeholders and a joint plan developed. However, this plan has not yet been implemented because it's kind of a multi-sectoral, and so we would require to mobilize the resources to be able to implement this plan at all the different levels. In the area of emergency response, we have secured resources to have the National Call and Dispatch Center established at Mulago, and also 4 regional ambulance and call and dispatch centers, that is Arua, Lira, Mbale, and Mbarara. The resources are available for those 4, and work is yet to begin to make sure that they are established. And we have already secured a universal access short code 912 from Uganda Communications Commission, but it is not yet circulated or publicized because the call centers are not yet in place. The increase in substance abuse disorders in our records was a challenge or an issue that we thought we need to address, and a number of orientation activities have taken place in schools with the religious leaders, politicians, and journalists in some of the areas, with focus on tobacco and other substances, and also engaged 80 members of parliament on harm-related alcohol use, so that we should be able to have the legislation in place to control the alcohol and substance abuse. So this is an area where sensitization is still ongoing. By then, we had a high dropout rate for HPV2 for the young girls. I would like to report that a revitalization plan was drawn, but largely looking at integrating HPV into the integrated child health days. And our records show that we have made some improvement from the 56% to 74% as of end of June 2023 coverage for HPV2. So we also plan to digitize this so that we can be able to track these girls and follow them up to complete their second dose through the school health program. Malaria is and remains a challenge. You know, we've had an epidemic which was running for the last 1 year or so. It has kind of reduced, but we have a number of interventions that have taken place, including a comprehensive mass media campaign, which for the net distribution to increase awareness on the benefits of malaria control, but more so on the use of the bed nets. And we have a malaria which was started on a number of can reach out to more people, and including at community level where 1,000 counseling guides have been provided for the village health teams. Indoor residual spraying was implemented in 7 districts, largely in Bukedi region, where malaria was really having a high toll in that region, and larviciding conducted in 10 districts in the regions of Chigezi, Eastern, and Lango. A total of 13 million nets have been distributed as of now. I think as we are ending this month, there are about 13 million out of the 28 million nets that we had targeted to distribute. So far, 78 local governments are covered, and we expect that by the end of this year, by December 31st, we should have all the nets out in the community. Another performance gap, and I would like to say is still a challenge, is the ART retention, which was 83 by last financial year, Unfortunately, it has reduced, as you'll hear in the report. So it is a big, big challenge, and we are yet to identify the factors that are leading to low retention. Yes, so this is an area that we have not really done much progress. The issue of neonatal mortality turning up to be among the leading causes of death in Uganda was to be addressed through capacity building. So we reached out to about 626 health workers with hands-on mentorship, with the Kawempe National Referral Hospital leading this with modular newborn care training. And we expect this will eventually have an impact. We have also procured equipment to equip our NICUs through the AMCHIP, and distribution is ongoing in several hospitals and local governments. In the area for availability of medicines, by then our issue, and it's still an issue as you heard, of inadequate funding, we only got an addition. The other regional referral hospitals are partially implementing, but we hope that with time, these would have the comprehensive system in place. We have also started on the general hospitals, and local area networks have been established, so that, and some equipment procured so that we can further roll out in all the general hospitals and subsequently to the health centers and other facilities. In the area of human resource, the key issue was weak performance management system for health workers. We committed to development of key performance indicators for managers and core cadres. This has been done and already being implemented in the regional referral hospitals. I think end of this month, the DG was calling out to all hospital directors to submit what they have so far picked up using this. So we expect that we shall continue learning in this area and scaling up, rolling out, so that we can be able to hold each other accountable. There was the issue of low utilization of the integrated human resource information system, and this is being upgraded so that it can be more user-friendly and capture more information that is required, and this is with support from USAID. We expect that by the end of the quarter four for this financial year, we should be rolling out the new integrated human resource information system. We also talked about the suboptimal community health workforce as an issue then, and area of action was to train more, invest in training, and as the minister mentioned, we were able to complete the 6 months training for the community health extension workers in Mayuge and Lira. A total of 334 were trained and commissioned and should be already and provided with tools. So we are yet to follow them up, but we still need resources so that we can train more based on that experience. For the VHTs, a number of tools have been provided, and they are continue being provided in all the regions, including some training. The Public Health Act, by the time we met, had been passed, the amended bill, and we are still working on development of the regulations in respect to the amendments. We also deliberated on optimizing the parish development model for strengthening community health programs. The final draft is in place. This was done as jointly as a human capital development group, including Ministry of Health, Ministry of Education, and Ministry of Gender. And the final draft is ready for presentation to to Ministry of Health top management. It was already presented to HIPAA, but as I said, the lead sector is education, but we have that manual already in place. There was the challenge of inadequate support for the private sector or inadequate capacity for disease surveillance. A number of interventions in terms of capacity building have taken place with up to 700 private providers in Kampala area trained between January and July of this year. And generally we have seen, because you know the majority of the private health providers are within Kampala metropolitan area, over 90% of the private health providers in the country. And through that capacity building, we have seen a great improvement in completeness and timeliness of the weekly reporting and in terms of disease surveillance. We have also continued with the rollout of the electronic community health information system in about 9 districts. We plan to extend this further to Mukono and Kamwenge, and also tool our VHTs with phones so that they can also improve on the reporting, as support supervision is undertaken by the local governments. Chair, lastly, we still had the issue of inadequate technical capacities and accountability at the decentralized level, and our main focus here was to build capacity of the regional supervisory structures. And this is being supported through the G2G funding, but we also expect that with the new structure that was approved, especially for the regional referral hospitals, we have the public health department where we have now a strong, if we are to recruit, we should have adequate capacity for the regional referral hospitals to support the local governments and more so on the public health interventions. And we are also glad to report that a number of, through the G2G support and through other partner support, a number of local governments are conducting regional performance reviews, and as a key linkage between support supervision and quality improvement. So, Chair, those are some of the key areas that we committed, and I'm glad that many of them action has been taken, because the last GRM was conducted in March this year. Up to October, we have made great achievements. Thank you very much.
Thank you, Sarah. I don't know at this time whether we have any question regarding what she has presented, but since we are going to go through the annual health sector performance, I suggest that we combine the two presentations and then we have the questions, because most of those questions are overlapping. So at this time, I want to invite the Director General, Health Services, to take us through the overview of the Annual Health Sector Performance Report 2022-2023, the key result areas. Thank you.
Thank you very much. Good afternoon, ladies and gentlemen, Honorable Minister, PS, Honorable Ministers, PS, development partners, and colleagues. I'm going to take you through the highlights of the Annual Health Sector Performance Report 22-23. And as many of you will recall, this is the gist of the matter of this JRM. It is a detailed presentation, but I'll try to highlight and summarize. Because we have the report, and most of the issues that I'll be presenting are in that report. So I'll run through really, because otherwise if I go in detail, we shall need 2 hours here. So I'll try to summarize this. If I can take 30 minutes, that will be the best performance I can try. But we shall see how it goes. So where do I do this? Here. Where do I show it when I want to move? Here. Here it is. Okay. That's what they call user training. So, ladies and gentlemen, this is our 23rd Annual Health Sector Performance Report, 29th Annual Health Sector Performance Report, and the 3rd of the NDP3. And as you know, this is our 29th JRM, so that means every year we have had this report prepared. And this report documents our performance during the year under review, and in particular highlights the achievements, highlights the challenges, and issues affecting performance. And the report will be presented in 2 sections, where we shall emphasize the key result areas, but also the key outcome indicators. And we shall also try to highlight the challenges with a view of discussing the challenges to guide the priorities for next financial year. Oh, sorry. Of course, the vision, mission, and the goal of the sector are in the report, and many of you know it from the strategic plan, and I'll not go through that in the interest of time. A quick highlight of the demographics. Our total population is indicated there, almost 45.8 million. But of note, let's look at under 1 population, which is about 1.97. That is a very important denominator as we plan for the sector. Also the under 5, you need to note the population there. You need to take note of the adolescents, as we'll be talking a lot about adolescents and youth, the expected pregnancies and expected deliveries, and women of reproductive age group. You may need to know how many facilities we have in the health sector. We have 3,416 public facilities, 3,743 private for profit, and 1,051 private not-for-profit, totaling 8,210 in total. Maybe you need to know that we have 4 specialized hospitals, which is Uganda Heart Institute, Uganda Cancer Institute, Women Hospital, and the Entebbe Pediatric Hospital. Many of you don't know the national referral hospitals. You keep thinking it is only Mulago and Butabika, but we also want to inform you that Naguru Hospital, Kirud Hospital, and Kawempe Hospitals are national referral hospitals. In this report, we shall be emphasizing key results of the health sub-program. As the previous speakers have said, the health sector is part of a program which is the social development program, where we are with the Ministry of Education, Ministry of Water and Environment, Gender, and Ministry of Health. And that is very crucial as we talk about the contribution of the other sectors to the health sector. But us, as a sub-program, we have 3 key result areas, key results to deliver under the program. One is on increased life expectancy, and the second, our mandate is to reduce neonatal, infant, under 5, and maternal mortality rates, and the 3rd, which is to reduce fertility rate. And there are 31 indicators under these 3 key results, and I'll be running through them. And these indicators are in your book. They cover quite some time, so for that matter, I'll be running through them very fast. Now, you need to note here that we have 31 indicators. We have 2 indicators on improving the skills mix in the health sector. Then we have 15 indicators on reducing morbidity and mortality of the population. And we have 8 indicators on improvement in the social determinants of health. Maybe I can do them concurrently. In the first 2, we achieved both the 2 indicators, as I'll be highlighting, on skills mix, on reducing morbidity and mortality. We achieved 8. 2 are in progress, but the 4, the 2, I think, these things are small from here. The 2 we did not achieve. All those in red we did not achieve. And then reducing fertility, which are 3. 1 is in progress and the 2 we didn't achieve. Then universal health coverage, 1 indicator we achieved, 3 we didn't achieve at all. Then all key forms of inequalities reduced, 1 indicator which is in progress. So in total there are 31 indicators. We achieved 15, which is about 48%. 6 of them, about 19%, are in progress, and 10 we didn't achieve at all, but 1 we didn't assess. This is an important slide for us. That's why I'm taking a little more time on that, to see what did we achieve over the period under review, what is in progress, but also to note that there was a significant number of indicators that we did not achieve at all. This year there was improvement in assessment, because the previous year we are out of these 31, we were only able to assess 21, but this time we were able to assess the 31, the 30 except 1, and earlier we only assessed 20. So at least there has been an improvement in assessing these indicators. Now I'll quickly run through the 31 indicators, and as I said, these are in your documents, so I'll really be running through. The first ones are on improving the skills mix. The first one is on the proportion of the health workers that we have in the sector. This we did well. It improved to 2.7 out of 10,000. Here we are using a proxy of nurses, midwives, and doctors. But specifically on doctors alone, we also improved on that we achieved 2, where our target was 1.4 out of 10,000, and we are at 2. Important to note that we have over 9,000 doctors in this country who have been registered, but last year, only 4,700 were able to get the annual practicing license. So the question here is, where are the other about 4,300? Are they in the country? Are they alive? Are they out of the country? Or are they practicing? So that is an area for the council to analyze and guide. Then we have indicators on morbidity and mortality, and I'll be running through. The first one is number of new HIV infections per 1,000. This is one of the indicators which we achieved. Then TB incidence rate per 100,000. Here, the target was 144, but from the recordings we got 199. It would look as if we didn't perform very well here, but the difference was that during this period we had the CAST campaign, and through the CAST campaign we were able to identify many more TB patients than we had actually initially envisaged. So the point here, the lesson is, was our target realistic? Because now we are finding more patients, TB patients, than we had actually thought. It would look red, but it is a good red in that we are finding more cases and bringing them under treatment. Now the issues of malaria, where everything is red, as you can see, in the previous years, 2020, 21, 21, 22, and 22, 23. In all those 3 years, we didn't achieve the target, but many of you also, you know, we've been having an epidemic of malaria for the last 3 years, and which started around 73 districts, I think earlier. By last year, it was 43. This year, the number of districts with the epidemic were reduced to 19, and as we talk now, there are 3 districts which are still under epidemic mode, and those are Serere, Kibuku, and Amulata. Of course, there have been very serious interventions to address this, but also to bring down the epidemic from 73 districts to 3. A lot of work has gone in. One of them, there are 4 major interventions. The first is indoor residue spraying, which has been going on in 7 districts indicated there. We are also doing larviciding in 10 districts and in 3 regions. That is in Kigezi region, in Lango region, and in some districts in Eastern region around Bukedi. We've also been doing seasonal malaria chemo prevention, and this has been done mainly in Karamoja, and all the 9 districts of Karamoja underwent this intervention, and this helped a lot to bring down the malaria problem in Karamoja. And of course, the treated mosquito nets, which are being distributed. You recall we last distributed the nets in 2020 in the midst of COVID, and we are distributing nets again this year. By December, we shall have completed distribution of nets in all the districts across the country. As of now, we are in phase 3B, and by mid-December, we shall be done with all 146 local governments. Hepatitis incident, we are doing well, but you also know that we introduced hepatitis immunization about 15 years ago, and also we have been vaccinating adults, and the vaccination campaign has been going on across the country. Annual cancer incident cases. You realize we don't have data in the annual cancer incidence rates. The only data we have is based on information from the Cancer Institute and from a few regional centers that the Uganda Cancer Institute has started, and the studies which are going on in Mayuge. So this is an area where the Commissioner National Non-Communicable Diseases, Uganda Cancer Institute, this is an area really we need to work on very seriously. We all know that the burden of cancer is rising, but we cannot tell precisely the information of how big the burden of cancers is in the country and how we can pick that through our routine HMIS. So this is an area for intervention for all of us. Annual cardiovascular diseases, we are also not very sure. We see our target was to identify 5,000. We are reporting 2,500 to reduce, but only 2,500. But the worry here is, are we really picking all the information and the data that we should be getting through our routine data collection systems? So this is also an area for NCD team with our HMIS team and the Uganda Heart Institute. I think I saw Peter Wab here. We need to spend time here and ask ourselves whether we are picking the exact information that we need, which should help us to do our planning. Incidence of road accidents, it shows that we have improved, but many of us also know that the problem is still big. I think here the problem was more of the baseline and our target, because you really see that since 20/21, 21/22, there has been increase in accidents, and even the period under review, this has even increased further. to 44.5 per 100,000. So that shows that the problem still remains. Maybe we should also look at the baseline, and we should also look at our target, whether it was realistic. Under 5 illnesses attributed to diarrheal diseases, they are all in red. There has always been that question that when we started rotaviruses, how come we still have a lot of diarrheal diseases? But some of the explanations which have been given by the pediatricians and others is that when we are talking about diarrheal diseases in children, many of the conditions they get also have symptomatic diarrheal diseases. A child with malaria will also present with diarrheal diseases. A child with otitis media may also have diarrheal diseases. And when it comes to our HMIS, we pick it as diarrheal diseases. So this is also another area we need to analyze further and see how can we pick the exact data that we need. Now, this graph shows road traffic accidents, road traffic injuries as reported at health facilities. These are the ones reported in health facilities, and the blue is the previous financial year, and the red is the current financial year. What it shows literally, except for Kampala and I think Kampala, and maybe Toro, the previous year was worse than the current year. But in Kampala, this year was worse than the previous year. The maternal mortality has been talked about previously by the previous presenters. We improved from 336 per 100,000 live births to 189 per 100 live births, about 44% reduction, and we really appreciate that achievement. Neonatal mortality rate almost remains stagnant, although we made some progress from, the target was 17, but we're at 22. It was some progress. Well, the previous 2 years, we didn't have the data because we picked this one from UDHS. And the same with under 5 mortality, where we have made progress to 52. But the curves show you the steady progress that we are making for infant mortality, under 5, and neonatal mortality. But if you see the line of neonatal mortality, literally, it's not really slanting, it is almost horizontal. So we cannot be so proud about that as any significant decline. Those maps show the areas, and this is from the UDHS, of under 5 mortality by region and under 5 and infant mortality by region. And this is in your maps, in your report. The leading causes of mortality is neonatal conditions, followed by malaria. But the argument has been, because this is health facility deaths, and the argument has been with regard to malaria, we have not picked the community deaths. So this picture may not portray the true picture about the deaths for malaria, because it only portrays the deaths in health facilities. So it is neonatal conditions, and I think this also highlights the point which Peter talked about in the keynote address, where we need to reactivate or to put in place NICUs in most of our regional referral hospitals and in most of our general and even health center force. That should be an area for investment that we should prioritize. Hypertension, this is based on the National Household Survey. It still shows that we are still below the target. We have not yet achieved the target of the hypertension rate, although we have achieved that for diabetes and for communicable diseases, as you can see. Mortality attributed to unsafe water and unsafe sanitation and lack of hygiene has reduced, and we have met the target as indicated there, and this is based on World Health Statistics report of this year. We now want to look at the social determinants of health and safety. The prevalence of teenage pregnancy. Everybody has talked about this since morning. It is 24 from 25, which was in the last UDHS, which was 2016. You can see a 1% drop is not something that we can be proud about. And this is an area that we need to think about and work very seriously to address. And some of the proposals were made by the keynote speaker. One of the interventions is really how do we work with the Ministry of Education to keep children, the girls in school. Because once girls are in school, then most likely they will not get pregnant. So this is a key indicator that I think either in our group discussions, we must find a solution to this. Stunting and wasting, we have also not made very, very significant improvements, but you can see stunting, underweight, wasted, and we also have obesity, overweight, as indicated in the program, and the details are in our reports. The prevalence of obesity, well, we've tried to improve on that, but we still remains a challenge in this country. So we are dealing with both undernutrition and overnutrition. Mortality attributed to injuries, I had already talked about it. It is still a problem, and this is indicated by the World Health Statistics. Alcohol abuse remains a problem, although we have reduced it. But as we've been saying in the past, we remain a big alcohol-consuming country. Uganda is #1 in Africa and the 3rd in the world, with a consumption rate of 12.2 liters per capita per annum. And this means, I was told that this means hard liquor, actually, when they are describing it. It means hard liquor. And the men were around 19. We are only helped by the women, who are around, is it 4? To bring it to 12. But 12 is very high. On average, most countries are around 4 or below 6. So if you find you are around 12, that is a very, very high alcohol consumption, and we need to do a lot to bring that down. And one of the areas in a meeting we had last week, and it was brought to our attention that one of the biggest challenges in Uganda is how we are promoting the alcohol industry by allowing them to advertise, even including on our own health programs. That you define it as a health program, but you have Uganda Breweries is the one advertising there, promoting the alcohol consumption. You find that they are also giving us some equipment, and they come and they advertise, and we are there, big people, like really endorsing their alcohol. So that is an area we need to work on very seriously. Improved sanitation facilities. You remember we were at one time at 19%. We went to 24, and we are now at 44. I think we are doing very well there because our target was 32. But of course, we need to do it even better in terms of improving our sanitation facilities. And when we talked about improved sanitation facilities, we are not talking about any latrines. We also talk about improved pit latrines and WC system. Improved hand washing facilities, there's also great improvement there, up to 49%. We met the indicator of 42%. Fertility, this was also discussed at length. 5.2, we moved from 5.4 in the last demographic health survey of 2016, but that is also really a marginal improvement. from 5.4 to 5.2 is not a very big improvement in 5 years. And we really need to look at the issues of family planning and the unmet need for family planning in order to address this. The fertility by region, apparently Karamoja seems to be leading with 6.7, and the lowest is Kampala 3.7. So our girls in Karamoja are really delivering a lot. And adolescent facility, now this is an interesting slide. Adolescent fertility rate, that per 1,000. You can see our target was 132. We have 128 per 1,000 of our adolescents. Our target was 128, and we achieved 128. But that is by World Health Statistics. But surely, I don't think we can be proud about that also, although we have achieved our target. You see Rwanda, 31. See Kenya, 73. See the Africa region, 97. The global average is 41. And we are 128. So can we say that we are doing well? Certainly we are not doing well. I think that is an area we seriously need to look at. Unmet need for family planning, 22%, but there's still a lot to be done. The program and all of us must think hard with all our partners how we improve on that. Percentage of currently married women using modern methods, 47, and those using traditional methods is the line below. But also, I think much as our graph is going up, it's also an area that needs a lot of improvement. On universal health coverage, population assessing health, our target was 17, and I think we are at 2.1? Yeah, 2.1, very poor. Then out-of-pocket health expenditure, apparently we have reduced out-of-pocket health expenditure and increased on government funding, as I'll be showing later. This out-of-pocket expenditure used to be around 41. It came to 36, and it is now 29. I think, Peter, you were showing something still around 36. Yes, so I think we have improved in that area. And you can see there, the public funding is the blue one. Private funding from around 2019 is reducing, and donor or development funding still remains high. Of course, that still remains a problem when you have such a high proportion of donor funding. Issues of sustainability come in. Readiness of our health facilities to deliver, to provide general services, we are not doing very well. And this one is normally assessed by looking at the amenities we have, the basic equipment, IPC facilities, PPE, diagnostic facilities, and we assess each facility, and those are the scores. We are really not doing very well. And the SCAP department has been very key in this area of assessment, and we need to address some of these readiness indicators. On the issues of proportion of the population assessing universal health care, while we have moved and we have progressed to 49, we haven't achieved the target of 53. But the indicators show that at least we've made some good progress on the tracer indicators for service coverage, as I'll show in the next slide. When you see Uganda, we have moved from, I think, 22 to 49, while on average Africa remains at 44, and the world, the global, is at 68. So Uganda, we are at 49, but the target of 90 should be met by 2030. And we have, I think, 7 years to go. So now we need to work very hard to address this. Now, I'll quickly run through the outcome indicators. The beauty is these have been highlighted already, and many of us are very familiar with this. But the point to start with is that we are declining. This year we declined in all our immunization antigens. As you can see, the pentavalent and the measles vaccination, we are in red. We had, these are the districts with poor measles coverage: Mbarara, Arua, Masindi, Soroti, Kasanda. But also during this year, we had an outbreak of measles in 5 districts of Koboko, Lamu, Kiryandongo, Bundubujo, and Kampala, as you can see. And regarding percentage of children, 12 to 23 months with all basic vaccinations, as per the UDHS, you can see 2022 is 54. The previously in 2016 was 55, so there was a decline there. And I'm sure we should be getting worried, because from 55 we should at least be in 60s. And the number of no vaccination at all is at least reducing, but 2% is also a bit high. Use of nets, we didn't have data for this year. The last data we had, mosquito nets, was for last year. Even last year we didn't have, but the target was 78, but we didn't have data because we didn't do malaria indicator survey. And we are planning to do that next year. The population with knowledge about mosquito nets, we also didn't have data for the same reason, because we did not do the malaria indicator survey. HIV pregnant women are initiated on treatment. We are doing very well, 94%, met the target of 94%, but remember, we are targeting 95 according to the UN targets. But EID, for the infants, we are not doing very well. We are at 95. We've made progress. The target was 95, but we're at 91. So the program, you need to find out the challenges associated with that, and we need to address that. ERT coverage, 98%. 98%, and we are doing well there. And the figures are there, those on treatment and those expected. So if we look at viral load suppression, the target, you remember, was 93, and the red line shows you the districts or the regions which achieved that target from Toro, Busoga, Lango, downwards up to Kampala. What is important to note is these districts, regions which did not meet the target: Karamoja, Bugisu, Teso, West Nile, Acholi, Bunyoro, and Bukedi. So we urge the program and all our development partners and implementing partners active in HIV to pay special attention to these regions. TB notification, as I told you earlier, because of the increased input through the CAST campaign, we were able to pick more cases per 100,000 than the target. That's why it is red. But as I said earlier, that is a good rate because we are picking more cases. So what is important now is maybe to revise our targets. Leprosy, we are also picking more cases. There's also increased identification of leprosy patients, and we have been able to pick more cases. That is also a good rate. And that's the map showing TB case notification rates across the country and the CAST campaign. Target population fully vaccinated, 56%. I think that's the same as I talked about earlier. Zoonotic diseases detected during the year. We had 4 zoonotic diseases which were detected and promptly responded to. We had the Ebola outbreak, many of you know, that was in 9 districts and was promptly responded to. We had anthrax in Kazo, which was responded to, Rift Valley fever in 5 districts, and CCHF in 10 districts. But all these were responded to. Maybe that's why you didn't hear much about them. Target districts that achieved elimination of blinding trachoma, we achieved the target of 88 and we got 90%. And there are 6 districts remaining, but are still carrying out mass treatments and surveys for trachoma, and we believe this will also be handled very soon. Now, regarding vaccination for hepatitis, we are doing badly for all the 3 doses, the first, second, and third. But it also, we know that we also ended the vaccination for hepatitis, I think, last year. And I think the program will advise us. But we are not so worried about this because, as you know, we started vaccination for hepatitis over 15 years ago. So we should be, at least most of our children and young adults must be protected by now. Cervical cancer screening, we don't have data. Breast cancer screening, we don't have data. Prostate cancer screening, we don't have data. And as I said earlier, we need to work very closely with NCD program, department, Cancer Institute, and Mbaka and your team to make sure that we get this data, put in place mechanisms for getting this data. Because it's very important to have this data, and we can plan better. IPT coverage for pregnant women, we missed the target, 54, our target was 66. And screening for anemia at first antenatal care visit, we are also doing very badly, actually achieved less than a half of our target. So reproductive health program and all our partners, that is an area we need to work on very seriously. Antenatal care fourth visit, 46%, our target was 52. We declined even from the earlier last year, so we need to seriously look at the reasons for failure to achieve that target. Very good coverage was noted in the cities especially, Soroti, Lira, Mbarara, Jinja, and Kiruhura. But low coverage is Namutumba, Madi Okolo, Soroti, Wakiso next door here, 25%, and Buvuma, 24%. The program should see how to help these. Now, I was discussing this with my colleagues. If you look at UDHS, it shows us that fourth antenatal care visit is 72%. And when we go back through our routine information system, it shows 46%. So there is something to discuss there. What does that mean? The UDHS went in the community and picked 72%. Our routine data is bringing a much lower figure. What does that mean? Are there facilities that are not reporting, especially the private sector? Are there? So what is, that's area for discussion, and we need to find out where the gap is with respect to this. Health facility deliveries, again, during the year under review, it was 64%. 70% was our target. We missed the target. But as you know, UDHS gave us 91. So where is the question? Do we still throw the blame to the facilities that are not reporting? Most likely the private facilities. And you remember when I showed you the first slide of number of health facilities, the private health facilities were really quite many. They were almost, out of the 8,000, they had almost 3,000 something. So if we have private health facilities delivering but not reporting, that can be a problem. And the deliveries at home are reducing. Health Center Force providing comprehensive EMOC. We didn't achieve the target actually. Our target was 70%, but we achieved 52%. But there was an increase in number of health center force, where there was a marginal increase from 131 to 132 in terms of health center force providing this. The number of health center force increased to 254. So we are looking at those which are giving cesarean section plus blood transfusion. Now, my problem comes here, cesarean section. We are having 87 in government percent, 93 overall, including PNFPs and PFPs. Performing cesarean section and providing blood transfusion, 57%. In government, 57% overall. So in government, you have 30% not providing blood transfusion but doing cesarean section. Tight rope, you can see. Somebody has to intervene in order to save a mother, but you are also walking a tight rope because suppose something goes wrong and you require blood transfusion. So this is a very important slide for all of us to note and see how we can address that. During discussions in HIPAC, we had even discussed with most of our implementing partners who are in the regions to help with fridges for blood transfusion. Because really blood transfusion, we are really talking about a fridge at a health center for and how we can come in. Health center force with the highest cesarean section rate, you can see them. But to note here are the private for profit. They are really doing a lot of cesarean sections with cesarean section rates of up to 74%, 70%, 67%, 62%. So, and the earliest government health center for is at 41%, Ruekubo and Serere 40%. So, Mugahi, we need also to discuss with our friends and brothers in those health center fours, those cesarean section rates, the justification and the reasons. And quite a number of them are doing so even without blood of 74%, but with no blood transfusion facilities. So, maternal deaths among per 100,000 within our health facilities. Our target was 70 per 100,000. This is institutional, but we declined to 90 per 100,000. You remember we had 92 in 2020. Then we came to we came to 85 in 2021, and we had thought we would hit 70, but we have gone back to 90 in our health facilities, and that is also an area that we need to seriously look at. And as we said, the commonest cause is hemorrhage, followed by hypertensive disorders and sepsis. Facility-based fresh stillbirths, you remember Peter talked about this a lot, and you know fresh stillbirths is a reflection of maternal services in the health facility. We achieved the target, but we are still losing 6 per 1,000 deliveries. Maternal death reviews, 89%, target 85%, perinatal death reviews, 43%. Under 5 vitamin A, second dose, 72% met the target, and met the target for women receiving ferrous and folic acid, 67%. Younger people in school assessing age-appropriate information. We don't have data. UNICEF, you can help us to see how we can get that data going forward. Essential medicines, we look at a basket of 41 commodities, and let's look at the Q4 of the last quarter, the issue which was raised by the chairman, Local Government Association. Overall, Availability of the commodities in the last quarter was 58%. And for the basket of commodities, 58%. But I want you to correlate this with the next, with the next slide. It shows, if you look at quarter one is the black, then the red is quarter two, yeah, that orange, quarter three, purple, quarter four. You can see that consistently for essential medicines, ARVs, TB medicines, lab supplies, reproductive health supplies, there was a consistent reduction from quarter one to quarter four. But the slide I wanted you to see is that while we had 58 in health facilities, there was 82% availability of commodities in national medical stores and joint medical stores. So certainly the problem was the distribution from national medical stores and joint medical stores to the health facilities. And many of you who have been around, we have discussed that at length, especially regarding facilitation of the distribution system. But also, to confirm that at least health facilities were reporting, you cannot attribute this one to non-reporting. We see the completeness of stock status of the supplies and the essential medicines was actually good, up to 96%. So they reported, and because sometimes you could think it was because of poor reporting, but at least the facilities reported. Also, this shows that there was a reduction in the budget for medicines from the previous year, from 600 billion to 513. And I think the explanation there, I think we got more funds in the previous year for COVID vaccines. That's what raised it to 600 billion. Health financing. Let's look at the outside column. 77.2%, 19, 20, 2021, 6.1, 7.4 the previous year. This year under review, it was 7.6. Of course, still far below the Abuja target, but at least it shows that we've been consistent and there's some progress in funding for the health sector. The growth in the health budget, we also got a supplementary of around 318 million, I think. And that brought our budget for the year to 4 trillion for the health sector. 92% of that was released and 85% was spent. The expenditure, the budget absorption rate was low for projects, as indicated there. The release for projects was 86%, and the expenditure for projects was 68%. We are looking at those projects that bring the budgets through the Ministry of Finance. This does not include the projects that are off budget and whose budget is not captured in the MTF. Reasons for low absorption, especially the project funds, was mainly late release of funds, the delayed implementation of projects, especially related to usually procurement processes, and mainly construction, because some of them were due to construction, and when there's a delay in the construction, then you cannot pay. You only pay for what has been done, and that led to the delay in especially the project funds. With government funds, the delay where we absorbed 96%, the 4% was mainly related to wage for vacancies that were not filled, and there were also funds released a bit late, almost in June, and were swept back to the consolidated fund. League table. You know, we do a league table and we use certain indicators, and we categorized the best performing districts. The best performing districts this time were Kiruhura, Lira City, Manafa, Soroti, Rwanda, Bushenyi, Napak, Kabong, Sirong, Nabilatu, Kabale. A big clap for those. Can I request for a very big clap for Napak, Kabong, Sironko, and Nabilatu? In the previous year, these districts were actually very far in the league table, over 70, but this time they're among the top 10. I want another big clap for Karamoja. This time Bushenyi was overthrown because it had consistently become the number 1. Now, I'm not usually proud to list these, but I have to list the bottom 10. Chairman, Kawarole District, Kikube, Wakiso, Arua, Chankwanzi, Hoima, Bulisa, Soroti, Masindi, Lira. But that's not Lira City, it is Lira District. So, Lira District, Honorable Minister, we have to do something about Lira City, Lira District. But we have to see how to help this. We have to look at the indicators and why these districts didn't do well and see how to help them. It's not, we are not displaying them for shame. We are displaying them to see how do we help them to come out of this. Because that's what we did last time when we helped Karamoja and it came out. So now we need to get this out of the red zone. Regional performance. If you look at the districts in regions, we see Bugisu, Kigezi, Kampala, and Karamoja doing very well, and Busoga and Bunyoro being the worst performing regions. The best regional referral hospitals, there are also indicators they use to assess the regional referral hospitals and the general hospitals. You recall we agreed that we should assess regional referral hospitals and hospitals based on the actual work they are supposed to do, not on how many outpatients they have treated, because regional referral hospitals have particular mandates, and it is these mandates they used to categorize them. So Mbale ranks top, a big clap for Mbale. I think they are repeating, I think again, last year they were the best, I think. Followed by Hoima. That's a big improvement for Hoima. Hoima has been persistently a problem. St. Mary's Lacho, and for your information, we are categorizing both PNFP and government. Masaka, Arua, Lira, Fort Potro, Jinja, St. Francis, Zambia, Mubende in that category. Top 10 general hospitals, Kitugum, a big clap for Kitugum, of course. Mukono, Abel has been doing very well, actually. Angal, Ajumani, Kawolo, Katakwi, Amuria, Ambrosori, Kalongo. Oh, Kalongo needs a big clap. It is up there. And Iganga. Top 10 health center force, Mukuju, Ntororo, Magodos, you need to be appreciated. Bujubuli, Nchegegwa, Kabuyanda, Isinjiro, Goli, Nebi, St. Paul, Kasese, Kyangwali, Kikube, Rwamwanja, Kamwenge, Budaka, then Bukuku, Fort Potro City, Serere, in Serere districts. The Vice President will be happy to see. Hey, Vice President is Kataku, I think. So, in summary, I think I've already gone through this, the issue of that we have achieved at least the targets for health worker. Implementation of the structure, we have talked about that. But Sarah also talked about the performance indicators for our health workers. Because we are now going to continue assessing the performance of our health workers. Not just a question of being a senior consultant in a hospital, we must also see what exactly are you doing there. And that's what number 3 is talking about. We have talked about reduction in morbidity and mortality, the issue of the TB and malaria indices. We have talked about the HIV, infants. We have talked about the general decline in ART retention, especially coming down to 77%, against the target, low viral load suppression, especially in Karamoja, and we have also talked about all those. We have talked about information on cancer, that we need that. We have also talked about the weak or inadequate information in NCD area. We have talked about the increasing road traffic injuries, how we need to work with the police and other stakeholders, Ministry of Transport, UNRA, to reduce on road traffic accidents. High alcohol consumption, we must seriously guard against advertising, and we must support the bill that is coming. Very low coverage for health insurance of 2.1, the minister talked about that. External financing remains high, we talked about that, and we need to see how we reduce donor financing, increase government financing, and reduce on out-of-pocket expenditure. But we appreciate that the out-of-pocket expenditure has reduced to 25 or 26% as compared to 41% earlier. The per capita budget allocation of $22 against 86, we've talked about that, and low budget absorption of the donor-funded projects. Immunization, the worry about the declining coverage rates, almost all indicators, antigens actually. I think PS, we were discussing yesterday, I think it is only, DPT, but all of them are declining, and we need to discuss and find out about this. And I think the DHOs, you need to find an answer for this. You need to tell us why the declining rates, immunization rates, because we've been doing well for many years. Why are we going down? I think that's the same. Total fertility rate, we need to bring it down below 5.2. Minimal rate, the issue of teenage pregnancy, we certainly need to bring it down. The low uptake of contraceptives, we cannot be proud of 35%. We need to increase the increase in institutional mortality rate back to 90 when we had gone down to 85 is a source of concern, and we need to address that. The decline in IPT and forced antenatal visits, we need to address that. Screening for anemia in pregnancy, we need to address that. And the issue of providing blood and cesarean section, especially at health center FOS. And slow reduction in nutrition indicators, we need to address that. Ladies and gentlemen, in conclusion, the health sector has made progress towards achieving or improving the health status of our people, their safety, and management of a number of conditions. And we have achieved 48% of the annual targets. We made progress in about 20%. We did not improve in 32% of the targets. And only one indicator was not assessed. So really we made a progress, and we should appreciate that. But notably, over the last 5 years, in line with the UDHS findings, I think that has been emphasized. I don't need to repeat it. And this calls for a whole government approach. If we are going to address all those, to continue improving on all those, it cannot be the health sector alone. It has to be all the sectors involved, all our development partners, the private sector, the civil society, implementing partners, and all of us. And even the community, the population themselves, the parents. If we are talking about teenage pregnancy, the parents have a big role to play also. So all of us have a big role to play. Thank you very much. I don't know how much time I have taken, but that brings us to the end of this presentation. And when it comes to answering questions, I'll mobilize all my heads of departments, my directors, and my donors, development partners. We shall answer those questions together. Thank you very much.
Thank you so much. Now it's time to get the questions. Okay, so I've been guided that in order to have effective discussion, we break off now for lunch. And when we come back, we'll be receiving all the questions. And maybe also to make it quicker, you can note down your questions and you forward in case we will not have enough time. So I want to really thank all of you, but specifically I want to thank the presenters on the last session, DG and Sarah, for the detailed presentation. Thank you so much. So we are giving ourselves 45 minutes. Is that okay? 45 minutes, right? Thank you. So I think we are going to have lunch down. The organizers. We are going at poolside. That's where lunch is organized. Thank you very much.
And at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. Climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. The scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. I say, concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa. Uganda is a fairy tale. You climb up, and at the end, there is a wonderful new world. scenery is different. The vegetation is different. The climate is different. And most of all, the people are different from anything elsewhere to be seen in the whole range of Africa. Concentrate on Uganda. For magnificence, for variety of form and color, for profusion of brilliant life, bird, insect, reptile, beast, and for vast scale. Uganda is truly the pearl of Africa.
God found me a woman, my woman, my priority. She fell in love with the wire. She means the whole world to me. Yeah, yeah, yeah. You love me better, better than I love myself. I just want you to know. You trust me better, better than I trust myself. I just wanna give you love. Cause when I close my eyes, I know you are right here with me by my side forever. Do you know how much I planned for you? Oh, pray for so long for you, darling. Be mine forever, I promise to never lay you down, baby, this is my vow. I belong to you, you belong to me. I give you my heart, ooh, yeah. This is my vow. When you see the red, I'll be your umbrella. I give you my heart, this is my vow. Mapenzi yetu itakuwa milele. We utaona, utaona, we utaona. It's gonna have any man. I love you like Christ left church. Nobody could take your place, yeah. You are my number one. And I'm gonna be faithful, make your day so wonderful. Honey, can I take your pain away, far away? You love me better, by my side forever. Do you know how much I pray for you? Oh, pray for so long for you, darling. Be my forever.
questions, you can forward the questions to me, or you can you can raise up your hand and ask the question. So we are going to start from the extreme. Can someone move the mic? I see the second mic here. I don't know where it's working.
Thank you. Thank you, PS. My name is Alfred Okwonzi, the District Chairman for United States of Arua. I rise here to make my observation from the performance report shared here. My observation is about the bottom 10 districts. If you look at the bottom 10 districts and the first top 10 districts, PSU have lessons, we have lessons to learn from there. If you look at the bottom 10, you will realize that the districts, the grandmother districts that created the cities, the performances are very low. Then if you look at the cities that were carved out of the districts, you realize that the cities improved. What does this mean? This means that there's capacity building, there's a lot of investment done in city while the grandmother districts are not paid attention to. And therefore, I have an observation here to say, if you look at Arua district, from 2018 up to 2022, PS and Honorable Minister, you will realize that Arua district has not been resting, has been busy carving out districts. 2018, we are giving birth. 2020, we produced the twins. We seconded the best of the district staff to go and start these new districts. By the time we realized that we did that, that was when there was serious understaffing. PSC will agree with me, and Honorable Minister, the acting DHO has been acting in that position for so many years, for the last 6 years. I'm 2.5 years old in the office. But I highly suspect that this kind of scenario where Arua district, the grandmother district, has been going through, has impact on service delivery to the people. And that is where I'm coming from. I'm therefore requesting the ban on recruitment for Arua district, that is grandmother district, be lifted, so that recruitment be done in this grandmother district to regain the former glory of the district. Number 2, this district has no hospital. I want to thank you and Honorable Minister, you upgraded Bondo Health Center 3 to a Health Center 4 status. But when it comes to getting essential medicines and health supplies for the Health Center 4, it is not there. The Health Center is still getting allocation for Health Center Grade 3. So a whole district being manned by a Health Center Health Center Grade 3. So this is the outcome. May I therefore request that, could you kindly go ahead to submit the list, the name of Bondo Health Center 4 that you have ably upgraded to NMS to get the allocation for Health Center 4, so that service delivery is not hampered. And finally, I call upon more support from Ministry of Health and also development partners and the NGOs here that come to the aid of grandmother district, which is Arua. Ordinarily, you will go and look for new clothes to make your mother look younger and younger. You have left this grandmother to move in rags. And therefore, I request for support. I submit.
Okay, so we have had that grandmother phenomenon with a mother, but I know that my honorable minister will answer part of the question you've asked. We are going now to take. May I request, please, those of you who are far behind, please, can you come and fill all these positions that are empty? Kindly, please. Can we see people move from behind and sit in these vacant chairs, please? Thank you very much. So, so can you move and take the questions? There are 3, and then you come this way.
Honorable Minister, the PS, the DG, and development partners, I thank you for this great opportunity. My name is Charlotte Muhechi from Think Well. Mine is a comment that relates to, I think, the statistic that has been shown on health financing. I see that from the most recent national health accounts, we are now quoting a reduction in out-of-pocket spending from about 40% to 29%. And I just wanted to caution the interpretation of that piece of data that is based on percentages. If we look at the nominal amounts, I think it's important that we report the nominal amounts of expenditure across those 3 areas. It is highly probable that actually out-of-pocket spending hasn't been reduced, but that the government spending has increased and development partners have also increased, which will bring down the percentage, but when the out-of-pocket spending is still high. So I just wanted to bring that clarification for our consideration. Thank you.
Thank you, Madam Chair. All protocol observed. I'm Beatrice Bale Nakaichi from Office of the President. I wish to commend the Minister of Health for a wonderful review report that we have had this morning, and also the statistics that you've tried to bring across in terms of information to some of us. Office of the President does undertake periodic monitoring activities, and so I wanted to propose a recommendation to one issue that has been consistent over time with government, and that is absenteeism. I'm aware that we have so many consultants in our referral hospitals and general hospitals in the country, across the country. However, we are having issues still where when we have our intern students, nobody is present for their supervision and probably also their training, and therefore something that has affected efficiency in the health sector. And while I listened in this review report, I've not had any concentration on who takes care of the interns, medical interns in this country. And yet we all agree that this is a very important force in the health sector. And therefore, who is therefore supposed to plan for this gap that is actually very important for us as a country? When you read records, you realize that in other countries like Kenya here, they have promoted the internship program of our doctors and nurses by giving more salary to those that work in the rural areas. And therefore it has motivated them to actually go to those areas where we have more vulnerable people with less money, but they get the service quite better than probably those that are that are too many in the urban area in case of Uganda. We've had statistics showing that we have more doctors wanting to work in Kampala other than working those areas where we have more vulnerable people to receive or to access the health services in the country. And so the question is to the presenter, what strategies are in place for the government of Uganda to probably come up with a strategy or a roadmap or a policy, even laws that govern this group of people who later on become good servants of government or good service providers to the communities? We've also had issues of having a surplus of doctors in this country. Apparently, you find so many doctors in their places, but the efficiency of a service, someone does not feel bad probably just providing a half-baked service to a patient and therefore seeing them die. Now, how are we going to control for this? I have a feeling that as a Minister of Health, if we controlled the incoming of doctors so that it is, you know, when Macquarie refuses a student from applying for doctorship, they run to any other university across the country, and we know these are very many as well. So what is the quality of a doctor that we are producing today as a country as we improve or enhance the health system in the country? So I feel we need to look at the entry of doctors in the country. Probably when we reduce the quality at that level, we shall reduce government expenditure on inefficiencies of these service providers, and later on we shall be able to probably solve the efficiency and effective levels in service delivery. And then also solving the issue of absenteeism. I feel if we recruit the doctors who wish to produce a service, then we shall not have doctors run out of hospitals. And then another food for thought, who supervises the consultants in this country? Because they are doing all they wish to do. They are never in hospitals, and therefore, who is concerned to say we need to check them? Should we start providing contracts, just like government of Uganda has provided contracts to the PSS, contracts to the commissioners, contracts today run to the principal personnel of government? And so what should we do for these consultants so that they know they are accountable to the people of Uganda, but also to the government of Uganda?
Thank you very much.
Submit.
Thank you. Next, please. We request that you make your comments or questions short so that we're able to give other people opportunity.
Thank you, Chair, Madam PS. I'm Dr. Kasima Mchunguzi, DHR Konjiri. My concern and comment goes to the performance report on the issue of center force that are not functional. We have noted there is this general and blanket ultimatum, no recruitment, and so on. But when you get to the ground, you find structures are in place, and maybe it could be one of the keys of a given puzzle, maybe an anesthetic officer who is missing, yet the doctors are in place. I would propose that the senior management of ministry takes it up to handle some of these non-functional health center force on a case-by-case basis, so that by the time we come back next year, we are able to show that from this time, we are being able to functionalize X and Y. If, for example, there are two doctors and there is no anesthetic officer, we can ask for a waiver for a given district to recruit what? An anesthetic officer for a health center in a given area to functionalize. Secondly, on health center force that are doing cesarean sections without blood transfusion, Rukunjiri happens to fall in that category. And one of the limiting factors is most of the facilities we have, much as they have the electricity grid, it is not very reliable for you to store blood at that facility using the hydro backed up fridges. So I would propose, if we can fast track the procurement of maybe the solar backed fridges like they did for UNEPI, those maybe could support some of the center force that are doing cesarean sections without blood transfusion. Because the biggest fear is usually you have the blood, what about the backup power for these storage facilities? Thank you very much.
Thank you, Dr. Patrick Agurusi, Country Manager for AMREF. I want to take this opportunity also to thank and congratulate the Ministry of Health and everybody here for the great milestones that we have made. My question is really about the guidance of the Ministry of Health on strengthening the strategies of preventing teenage pregnancy. What is the guidance now, noting that a few weeks back there was a suggestion, and now it seems to have received certain mixed reactions. What is the guidance on preventing teenage pregnancies? Because it has come out as a big burden, and it is shadowing our possibility of achieving the demographic dividend. Thank you.
So can we move this side?
Okay, thank you.
Chaunedros Yabazaire, Blood Bank. First of all, I'd like to thank the Minister of Health for the support. As you can see, we are constructing regional blood banks. However, the health sector strategic plan specifies that each regional referral hospital should have a regional blood bank attached to it. So we still have a long way to go, and I hope the ministry will put this in their planning. 2, for the available resources for that year, we performed over 100%, but still we fell short of the 1% WHO requirement for the country's population. So maybe if we get more resources, we can perform better. 3, the problem of blood distribution. Unlike national medical stores where they distribute blood, healthcare facilities are supposed to make arrangements to collect blood from the nearest regional blood bank. We cannot do the push system because, as you all know, blood expires and other facilities may not have the facilities for storage. 3, for all the healthcare facilities, including health center force, to get blood, you must be accredited to receive blood by the nearest regional blood bank. And in that accreditation process, you must have a power backup, you must have the cold storage system like the previous speaker has said. So there's no way we can give you blood when you don't have those facilities in place. So I thank you, and I hope all directors will make arrangements to make sure that you have a budget to collect blood from the nearest regional blood bank. It's not blood bank to send blood to you like NMS. You have to have the budget, you have to have the personnel, you have to have the cool box to collect blood, and you have to have the cold storage facility in your healthcare facility, including the power backup. Thank you so much.
We are going to have 3 more, and then we give the DG and Sarah to answer, but also we can answer any of those questions, including Honorable Minister.
Thank you very much, Madam PS. My name is Dr. Namara. I'm from HMU. I agree. I heard a question that Dr. Kagurisi raised, and I hope the minister will give us an answer in view of that adolescent fertility rate, the teenage pregnancy, and yet our gallant MPs are really talking out of tandem about contraceptives for adolescents and the youth. So maybe you might give us some guidance there. The second question I had was on the HR for Mwebesa. Yes, we have increased the number of doctors from 8,000 to 9,000 plus. I don't remember how many, then the nurses. But can we decompose these medical personnel into the cadres? How many of them are, for example, anesthetists? How many of them are medical officers, special grade? How many? Because there is relevance in terms of health delivery care. And I think there may be a good relevance on why some areas may not be performing very well. And then this touches on the issue that was raised by research, where somebody is asking our keynote speaker to help them in research, management, and the rest of it. If we had very good cadres at the district health officer with the necessary competencies, they should be able to crunch this data. They should be able to give real-time data to the PS and the DG and the minister. So I think there's a problem on human resource management and human resource deployment, the quality, the quantity, and the technical capacity. Lastly, I had a rather disturbing, I don't know whether I misunderstood it or something, on CS cervix screening. Very, very poor uptake, and yet this is one of the oldest things that we could possibly have done for purposes of screening CS cervix. Is there any good reason? I think 71% of the mothers were able to attend antenatal clinics. Are we not able to catch some of them for screening, for CS cervix? Because this is one of the biggest killers, as we all know. Thank you.
Hello. Dr. Triabwe Stavia,
Assistant Commissioner in charge of TB Leprosy, Minister of Health. My comment is an observation on the report, especially among the top causes of death. Whereas in the causes of admissions, TB doesn't occur, when it comes to those who are dying, it is among the top causes of death. And this speaks a lot in terms of the quality of care at the point of admission. I see a lot of admissions from cough or cold and pneumonia, and I think some of these could be missed opportunities for identifying TB at admission and treating it early and only being found at the point of death. I want to call upon all the managers at the local government and the regional referral and health service points to think TB, because Uganda, we are still among the highly burdened countries, before we treat for pneumonia or cold. Thank you.
Yeah, thank you very much. Asiku Abdul Mutwalib, the LC5 chairperson of Yumbe. Madam Chair, when there was a presentation regarding the mortalities, it was reported that West Nile, under 5, the mortality is at 79.1%. This must worry the whole country and the ministry. My concern is, has the ministry interested itself in trying to find out what particularly could be responsible for this? And in any case, what uniquely needs to be done to save the situation in West Nile? 2, under the Comprehensive Refugee Response Framework, we are talking about integrating refugee operations into the mainstream government activities. I want to thank Office of the Prime Minister and also the MDS that we have been on track in the integration process and the transitioning. However, as refugee hosting districts, our biggest concern is still resources in response to this. Why I'm saying this is, as I talk, there are districts in West Nile that are going to implement the indoor residual spraying. And when it comes to the resources that have been allocated for the indoor residual spraying, the refugee population has not been factored in. And this makes us to continue asking the partners within the region to give us support. Sometimes they claim they don't have budget lines for this. So this frustrates the implementation, the smooth implementation of the programs. We have had the concern of quality of doctors, and I am very optimistic that we've been renewing licenses for these doctors. For me as a lay person, someone is called a doctor if this person can do surgery. And if the person is not able to do operation at that level, then this person fails to qualify to be a doctor, though he has gone through the training. So I think there's a need to look at, just as said, the quality of doctors that we have, because if we are talking about the new structure, where in a health center 3, we are supposed to have a doctor, then we expect this doctor to do all that is required. I also want to make a recommendation that when you look at this joint review mission, it's very important, and the stakeholders that have been invited in this joint review mission are limited. You'll find in a district, maybe the DHO is invited, the district chairperson is not part, the RDC. So if we could regionalize these joint review missions so that we are able to look at what are those region-specific concerns and what best has to be done in order to improve the healthcare systems in the regions. Lastly, on the rollout of the community healthcare interventions, I'm glad that the ministry has started it in the 2 districts of Mayuge and Lira. I would recommend that if this is rolled out to all the districts so that the communities are able to benefit, from the interventions thereof. Thank you very much.
Madam Chair.
So after we've had that question, then we'll come back to answer, and then we'll give you another set of opportunity to ask.
Yeah. Madam Chair, I thank the Ministry for the good performance, but I want to comment on the report about road accidents. Madam Chair, there are a lot of increasing road accidents every day. We are losing people. This is a health hazard in the country which is coming up. I propose that the ministry will develop a strategy to work with traffic, with the police traffic, to develop strategy to to reduce road accidents. People are driving recklessly, they are overspeeding, and the police doesn't care. We lose children, we lose adult people, we lose the prominent people in the country every day who are alive. So we need to get serious on this, get hold of the police, the traffic, and the road users. Also, we can put communication information on the radio to teach people how to drive and also how to prevent road accidents. I submit.
Okay, thank you so much. Now we come back to DG. Over to you.
Thank you, Madam PS, and I'll call on my colleagues also to support me in some questions. There was that comment that districts which produced cities, and the cities go ahead to perform better and leave the mother districts. And the minister wanted to answer that because she seems to be part of the cities which did well and left the mother district among the lower 10.
She can start on this one.
Thank you very much, DG. I know this question was asked in the 28th annual sector review, and it is appearing again. I want to refer all of you to page 68, 69. You know, statistics speak. It is not observation, statistics. When you go to that page, 68, the first 10 best performers, there are only 2 cities, Lira City and Soroti City. And when you look around, you will see that Masaka City is number 85, Arua is number 87, Mbale is number 34, Fort Portal 39, Mbarara 57, Hoima City 101, Jinja City 107. They were all produced by districts, all those cities. Again, if you look at the table, you can see districts that did not produce cities also performing very well among the first 10. You have a district like Manafwa, Napak, Kabong, Nabilatuk. In Karamoja, they are doing very well. Now go to the last 10. There are only 4 cities out of the 10 that are doing, 4 districts out of the 10 districts that produced cities, only 4 are there. The other 6 are not there. What does this tell you? Leadership, leadership, and leadership. Leadership, leadership, and leadership. Passion for work, commitment, mindset. And it is not only about the political leaders, it is even about you, the DHOs. How committed are you in supervising your work? Sometimes we visit districts and you don't find the DHO, you don't find the assistant DHO. They are not there, they are well, and nobody knows where they are. You ask how many times supportive supervision has been carried out, how many days. When you are recruited into service, you are taken care of by public service. So interns are in between. That means interns are a government issue. But you are not going to find any specific government that 100% pays for interns or provides positions 100% for interns. In other countries, you actually do your internship when a position becomes available. Then you are taken up and you're paid a salary. But here in Uganda, we are attempting to train all of them at the same time. Now, is it easy? No. And our economy is not as strong as some of the countries that you are talking about. However, there is a very good education for health policy that once it is approved by cabinet, you will have all the answers to your questions. You talk about a surplus of doctors, and yet efficiency of service is wanting. Enhanced add-ons. First of all, we are not going to control intake because our government feels, and we do agree, we are not only training for Uganda. We are training, anybody is free to train and go anywhere, but we must control the quality of training. Our biggest challenge with efficiency in service and better quality services, again, I'll give you 3 areas, but you can fill in the rest. Mindset. We are supposed to be responsible citizens. You have been recruited. Give to government what belongs to government, 100%. Dual employment. And we have failed to manage dual employment because we are not responsible people. We are actually thieves. We steal from government. You give government 1 hour, and you give your own private activity 7 hours. That is stealing from government. And by the way, there is a payment for it. In future, in heaven, you will pay. And then there is the issue of permanent and pensionable. Whether I come to work or I don't come to work, I will receive my salary. So those are the things killing us. And let me shout this loud and clear. As long as we have this bad mindset and attitude change, we shall never develop. Because it begins with you, with each and every one of us. If you are determined to do the right thing within yourself and not cheat and be truthful with integrity, you will see Uganda changing. But we don't love Uganda. All of us are determined to destroy our own country. Very beautiful country. However, the surplus of doctors that you are seeing, if we recruit all of them and deploy them in our health facility up to the level of a health center 3, which is the current policy, we are only waiting for wage. They will not be there. There will even be too few. Because according to our new structure, I think a health center 3 is supposed to have two medical officers. But you see, when it comes to quality of work, don't only complain about the doctors. It is teamwork. So we have to look at the entire cadre in the health sector. Now, adolescent pregnancy or teenage pregnancy is the reason why. For me, I believe, and I will tell you the reason why, that we have got our messaging, our messages wrong to address adolescent pregnancy. And the reason why, one of these days in cabinet, when we were discussing the high rates of adolescent pregnancy, and it was Minister of Education presenting after COVID, talking about the numbers of girls that got pregnant. Of course, I don't know whether we have good statistics, but we were challenged by His Excellency the President. And he said, I'm quoting him, since he was born, many of you can know when he was born, girls have been getting pregnant at 13 years, at 12 years. Girls are being married off. Even their own mothers were married off at 13 years and they delivered at 13 years. And it has continued. Up to now, even in some kingdoms, the kings are marrying young girls. And the girls are giving birth to babies. They are giving birth. Are they not giving birth? Yes. Jenna Cheng, are they not giving birth? Yes, they are giving birth to babies. So what is your problem? What is your problem? Just going around and telling young girls not to get pregnant will not work, because the mothers have not understood, the cultural leaders have not understood, the young girls themselves have not understood. So get your messages right. It used to happen in those days. Why don't you want it to happen now? What are the challenges? What are the health effects, the social effects, whatever effects? That is the message we should get out. But we sit and complain and say, stay in school, you won't get pregnant. How many people have gotten pregnant in schools? Staying in school is not a solution. We have to get the right messages to the girls. You get pregnant at this age, your body is not mature, your pelvis is not mature, you'll get obstructed labor, you'll end up with a fistula in the language that the populations understand. You will end up promoting poverty because you'll have so many children, you'll grow old. But we are talking to ourselves. And I'm telling you exactly what he told us. He said, you have the information, you're not sharing it out correctly. You're talking to yourselves. So we need to begin to talk to the population. And the good thing is that the theme is about communities. So can we talk to the communities in the language that they understand? I thank you, PS.
Thank you so much. Thank you. So, over to you.
I believe Kawanda has heard. And as soon as we get back, we have the right messages. Charlotte, we picked your comment, and I think it's a good observation. We should not just celebrate, but we should analyze exactly whether we are safe without out-of-pocket expenditure, or it is just the figures. And I think most of the issues have been addressed. Bondo. Sarah, let's handle that. The health center 3 was upgraded to a 4. They are still getting resources of a 3. I think that one we need to handle it. We don't need even to wait for them to write to us, because we are the ones who upgraded it to a 4. So I think, Chair, we have noted that and we shall handle that. Rukunjiri, you need to functionalize your health center 4s. Let's really look at the problem. Don't externalize that problem to the center. You've had many districts which are, their health center 4s are carrying out operations. If you have a health center 4 which is not carrying out an operation, maybe because of an anesthetist or maybe a surgical bed, you need to see how we address that, because it is really very useless and very hurting to have 2 doctors in a health center 4. You are paying them 5 million per month each. That's 10 million. And there is no single Caesar going on in that health center 4. It is like a health center 3, and it is very useless to that district. So we need really to address that. Warren, I think we have taken note of next time giving the breakdown of the human resource we have. We can give that details in the future. CS cervix screening. I don't know who will answer that. Why are we not doing cervical cancer screening yet we are having antenatal care? Who? Oyo is here. I haven't seen Oyo, by the way. I kept shouting about NCDs. I didn't even see him raise his head. You want to comment?
I just want to say something about the CA cervix screening. Initially, it was not a routine, it was not a widely done activity in all facilities, but it was after, in HIV clinics, it was introduced in HIV clinic, and then we started spreading, and so the statistics are not, we have not peaked to the level that we want, but this is the journey that we are on, and we hope that we shall get there. I wanted also to comment about the Buko. Someone wrote to us here that Buko used to get more funding. Over time, the funding was cut, Buko Hospital. I think Sarah, maybe you can give a bit of comment, but I know that Buko was performing suboptimally because it has not reached that level where we call it a hospital, because it does not have infrastructure that is fitting to be a hospital. But the good news is that we are mobilizing resources to do more infrastructure upgrade, and we hope that maybe next year you'll go back to getting the financing that you used to get. But otherwise, right now, your output was really not of the hospital, and really we now want to implement result-based financing. If you perform more, you get more support. On the issue of the human resource, there was a question here on. They are talking about the recruitment ban, and yet we have critical staff that are needed, but at the same time we have the wage, but there is a ban. We hope that public service, once they work with the Minister of Finance and they finalize the audit report assessment, that ban is likely to be lifted. But one thing I'm sure of is that still we are going to return the wage. That one I know. So the same problem that we started earlier, that we are returning resources back to the center, that's what is likely to happen, because the recruitment may not be completed for us to have these people consume the wage, because the wage is given for a year, yet the staff, if at all they are recruited, they come in the last quarter. So what happens? The money goes back. So that is something that we just need to get the right entities in the room and agree on the scheduling of the recruitment. When should we recruit? When should we declare a position? So that by July, come July, the human resource that is needed is recruited and is deployed in time, so that we are able to consume the finances that are provided. But one thing I know that also public service allowed us to recruit on replacement basis. So we should not hide under the ban for us not to declare positions and have the positions filled. Because if someone has retired, the wage is there, there's no question, there's no, but sometimes we go to slumber and we don't declare these positions, and then we only wake up when it is very late. So on replacement basis, we need to make sure that we declare the positions in time, so that they are recruited. The other thing is also that there are some critical staff in a way that they help to functionalize. For the sake of, for example, Rukunjiri, I don't know whether you have an anesthetic officer, but I know that some health center fall. Karenga, did you get your anesthetic officer? Good. You see, let me tell you, those who ask receive. But some people go in the district and just sleep, sincerely. But if you come and you said, I need this, because also we don't have these resources seated with us. No. But when you come and make a case, then we look for partners. There are partners who want to support. Maybe, you know, you knock at the door. Did Kwam help? You see? Because they came and because they come and articulate the things. We didn't have the money, but we had to look around. We said, who can help us? There is this problem. Who can help? Who can help? And because of that, we see the districts that have proactive leadership, where we see the leadership engaging relevantly, we see things get better quickly. So we encourage you that when you have a challenge, the functionalization, we have been, even now, I know off head, I know some facilities that, you know, they lack an anesthetic machine, they lack a delivery bed, but every time I get the partners, I'm like, please help me here, there is this facility. It is on my head, please help me. Because they follow up. But sometimes you get to facilities, they lack very essential equipment, and somehow they just write letters. My goodness, I get tens of thousands of letters on my desk. But you follow up with a call. Come. You're always in Kampala. Come and say, you know, I'm following up. We are on WhatsApp. WhatsApp has eased our communication. Take a picture of the letter you sent and say, please, what is happening? I've not heard from you. Can I know what is going on? We want to see that trait of leadership in us that is pro results. Because the functionalizing of Health Center 4, the facilities that have been very, very proactive, the leadership in the district that has been proactive, we had to be on tenterhooks until we do something, you know. You don't have a solution, but you knock at the door of partners and say, please help me here. And it is done. So we want to see that. So Rukunjiri, your facilities, if they don't have, for example, the fridge just to store, okay, leave alone the electricity capacity. Let us know so that then it remains on my list as first priority. When I get any partner that wants to support us, maybe Gavi, maybe US side, that's why I push my interest. And so we want to see that engagement. And with that, it is going to turn around. We have about 60 health center 4s. I think 60 or 80. Yeah, right, they are 80. There are 80 that we have targeted that we must functionalize in this year, where at least we have basic infrastructure. But because we do not have resources and we depend on partners, it depends also on how proactive you are in making your case. If I have very limited resource on my plate, if I have very little food, I'll give to whoever shows up first and shows the greatest hunger. If you come and you are first, you know, adjusting your belt and your tie, and you are just there looking at me, someone who is very hungry will come and eat that food. So for me, this is what we want. I'm just using this analogy so that it helps us to be more proactive. I hope that message has sunk. We are also lobbying. There is a project under that is supported by World Bank under Ministry of Energy, and we want to give priority to those facilities, especially for solar, to make sure that they are able to functionalize. So DHOs, if you know that some of those facilities, you just lack that capacity, that electricity, just to store blood, prioritize that so that then we can work on our list and share with the bank at this time. Thank you very much.
Thank you very much, PS. I think the rest of the questions are simple or easier. Are there planned interventions for indicators that are not captured? Yes, we are going to work on that, and many of them were on NCDs, Paul Mbaka, UCI, NCD. We should work on that so that next year we have those indicators. High cesarean rates in private health center force. I think MCH, we need to review that, and we need to work with those facilities and have in-depth analysis. And have in-depth analysis. Then there is somebody who is asking that we didn't indicate anything on occupational safety and health, including health workers vaccinated, health workers who got diseases and injuries, health workers who died in the line of duty, health workers who were compensated for death. I think the next report we should. Those are gender issues. Those are gender issues. Thank you very much for clarification. Then somebody has a question here, why Kabarole went down from top 10 to bottom 10. I think the question is for the district health team and the district leaders. What we'll do, if you look through the report, you'll see the indicators that we measure. So look at those indicators. Those are the indicators that put you in the bottom 10 and try to address them. So the point is why we show these. It's not that we want to embarrass you, but we want to encourage you to address those indicators. Then I think I'll ask Sarah to respond to some of the questions that I may not have responded to. When will the community health pilot projects in Mayuga and Lira end? Okay, this is for you, sir. They're asking, when will the community health pilot projects in Mayuga and Lira end? Those are choose. Why do they want them to end? I thought they want them to be integrated in the system.
So we are currently piloting in 3 administrative units, that is Mayuge, Lila City, and the Lila District Local Government. We had the training last year, and operations for the community health extension workers started on 1st November 2022. So we have planned to do detailed evaluation of this implementation in June 2024. However, we are expanding this, we are scaling up because we are all well versed with the relevance of community health workers, given the findings from other countries, more so from low and middle income countries. So we have received resources from World Bank to expand to Nakaseke, and engagements are going to start effective this new month. We are also scaling up to other 4 districts, that is Namutumba, Chotera, Kazo, and Koboko. So in total, those will be 8 districts. We hope that our submission to Global Fund will come through, and that will also enable us to be able to scale up to more other 3 districts. So DG, when the pilot ends, and after our evaluation next year, Ministry of Health will provide guidance on implementation. But what we are looking out for is for the districts where we are having the pilot of the community health extension workers, Our goal is continuity beyond the pilot. And the essence of the pilot is to enable us to be able to generate more information on the operations of the community health extension workers, to enable government to be able to provide more resources for nationwide scale-up. Thank you.
Okay, so now, I want to invite the next presenter. Thank you so much for the questions and answers, DG and Sarah and other people that asked questions. I want to invite the next presenter. That is budget monitoring unit. I hope that you've already loaded your presentation. They are going to present the assessment report for financial year 2022-23. Are they in the room? Okay, so can they load? Okay, then.
Meanwhile, there's an interesting comment here as they load. That in the future, even the Ministry of Health will be evaluated by districts that are scoring very low. That we shall also be evaluated by the district's performance. If many districts are scoring low, then the evaluation now comes on the Ministry of Health. Why are so many districts scoring low? Thank you very much for that comment. We have taken note.
Thank you very much. The Minister of Health, the Permanent Secretary, the Director General, all protocol observed. Good afternoon, ladies and gentlemen. My name is Sylvester Kato, and I'm here to present the annual performance of population health, safety, and management for financial year 2022-2023. So that is the menu that we have this evening. But before I go to unpack the menu, I wish to thank the Minister of Health and the Permanent Secretary and all the technical staff for inviting us to share with you budget monitoring findings. It's indicative of the willingness to get feedback and work towards improvement. So we're grateful for the opportunity. So the menu, I'll take you through the content and methods we used, the color code system, overall financial performance, all the way to key takeaways for the next budget of financial year 2024-2025. In terms of content and scope, a total of 38 out of 54 interventions were monitored, and this translated into 70% coverage. That is for the entire Human Capital Development Program. But for population health, safety and management, 90% of the interventions as reprioritized in the third NDP were covered. Our analysis linked physical performance against the financial performance. So we relate the usage of funds versus what is achieved on ground. And in terms of methods, we employed both qualitative and quantitative methods to analyze the work. So the results therefore indicate if Ministry of Finance didn't release money to you, we don't expect you to achieve anything. But if we have given you all the resources, we expect you to translate them into results. So that's the color code. So where you see green, that will be very good performance. And where you see red, that is poor performance, which means that you achieved below 50% for outputs and outcomes. In terms of financial performance, 79% of the budget for the entire program was released, of which 87% was spent. Key to note here is that absorbing only 47% of the released funds. And the low performance for the expenditure under donor financing was occasioned by the non-readiness of some projects, whereas funds, we negotiated with the funders and gave us money. The entities were not ready to implement some of these projects. But also there were issues of weak capacity of contractors to timely execute the works, and also delays in issuance of no objections from some of the funders. And under wage, 98% was spent, but whereas that looks rosy, in real terms, 36 billion was not spent on wage. And the reason for the low absorption on wage included delays in recruitment or late submission of the recruitment plans. But of course, later there were effects of the suspension of recruitment pending completion of the Auditor General's forensic audit. But for cases where there was recruitment on replacement, there were no clear reasons why this had not been undertaken. But also there were instances of tendency to either secure positions for certain people while service delivery continued to be constrained. Overall performance of the program was at 66% for attainment of outputs and outcomes. Generally, the outputs performed better than the outcomes, with outputs scoring 68% against outcomes. That was in general. But there were reversals, notable reversals under health, where there were good outcomes at 86%, and also those under education at 74%. Note that the outcomes under health, these were impact indicators, and therefore long-term, and also so for education, so they did not necessarily use resources for the financial 22-23 to attain some of these indicators, which we have already discussed. Under labor sub-program, national accreditation for the technical vocation and education institutions, and also international accreditation for science, technology, engineering, and mathematics. These were all missed and only achieved the work-based learning policy. Under gender, the indicator that wasn't achieved well relates to gender-based violence. Under health, we note that the mortality indicators, 2 out of 4 were achieved, with maternal mortality rate being achieved, and so was the infant mortality rate. The program, however, missed the under 5 and the neonatal mortality. Under family planning, this was at 37%, while the total fertility was at 5.2. These have already been talked about by the previous presenter. So health and the entire sub-program for working hard to attain these are NDP3 indicators, and you deserve a round of applause. Under education, the indicator that was achieved was net enrollment ratio for pre-primary that improved from 13 to 26, and also the proportion of pre-primary institutions that registered that also improved. Primary to secondary school transition, however, didn't perform well at 69%. We are having stagnation. People are not transiting from primary to secondary, so there are therefore high failure rates. Underwater, access to rural water was at 70 against the target of 80, and urban water was at 73 against the target of 69. And because of the low performance underwater and sanitation, we had cases of diarrhea at 60,000 cases of diarrhea, acute diarrhea. These were managed inpatient, of which 337 passed on. And we also had cases of dysentery, 4,027. These were managed at that level, and we recorded 52 cases of death. So this is not something to be proud of. We need water to manage some of these preventable diseases, as we know that majority of the diseases are actually preventable. In terms of gender-based violence, we observe that these continue to be high, with denial to resources at 24% and emotional abuse at 32%. As at 30th June, abortions due to gender-based violence that were managed at health facilities totaled 2,047. And those that were treated for injuries due to GBV totaled 65,000. Now, this is not a good indicator of having men and women harming each other and having some form of fights and GBV, because we can observe some bad outcomes out of this. I now want to turn to present the performance of interventions. As you observe, four out of the 9 interventions performed fairly, 2 performed poorly, and 3 registered good performance. Those that performed poorly, one of them is increasing financial risk protection for health, and this covers the health insurance, and also the one of increasing access to inclusive, safe water. That also didn't perform well. While the rest recorded fair performance. So I turn to present intervention by intervention in terms of what was achieved. The first one was improve maternal, adolescent, and child health. And some of the key achievements include 6 out of the 12 newborn special care units that were either completed or in advanced stages of completion. And these were Chiwoko, General Hospital, Mpiji Health Center 4, Sekanyonyi in Mitiana, and Bwera. We also observed that Kawempe and Mulago Specialized Hospital overperformed, so they attended to more neonates in their facilities. Whereas this is a good indicator, but it also again points to congestion and also a chance for cross-infections, because we're having many children, neonates, sharing incubators, which exposes them to infections. The clinical protocols for the management of small and sick newborns were also developed. But there are also some key issues which I wish to highlight. The first one is that we only have 4 neonatal intensive care units in this country. Now, this is not something good, as there are cases of mothers who want to be supported, either they've got prematures. So if you're in Kabale, you're in Chisoro, and you get a premature, what do you do? So this is a key issue which really needs to be addressed. These were only found in the Mulago Women's Hospital, in Zambia, Chiwoko, but now we need them in other places. Like previous speakers have mentioned, can we borrow from Tanzania or Bangladesh? But also key to note is that whereas these were in place, cases of shortage of neonatologists also continue to affect effective performance of these facilities. The standards for setting up and organizing neonatal care units across the country, these were not yet approved by 30th June. I'm hoping, Madam PS, that these have been approved to ensure that there are clear standards for setting up these facilities and also proper guidelines for supporting the management of these NICUs. Key to note also that when we carried out a comparative analysis between this 22-23 and 21-22, we observed some reversals with institutional maternal mortality increasing from 96 to 92 between the 2 years, and also deliveries declining. Now, these were interesting statistics, and again, this reminds me of what DG commented about, whether the issues of data quality, to have reversals in the results from the demographic survey, and then what we have from the health facilities. Or the other key issue to note is that overcrowding persists in the special care units and the NICUs. Was also not so good. And we also observed from our field findings that the 3 delays are continuing to contribute to institution. 7 out of 81 maternity wards were substantially completed. This was done with support from AMCHIP. And those that have listed in the presentation were lagging behind. And these were mainly in West Nile and in the northern Uganda. Those were lagging behind, but our recent visitation indicated that the contractor was trying to work hard to ensure that these are completed, aware that the project actually closed. I know they've allowed it to continue until the end of this financial, but substantively the project closed for AMCHIP. Then also to observe that critical reproductive maternal, neonatal, child and adolescent health equipment, family planning commodities, were procured and distributed to various health facilities across the country, including support from the GOU. The Ministry of Health also scaled up the installation of the electronic medical record system. But I wish to add at this point that in our visitation in some of these facilities, we observed that the system doesn't allow or doesn't have a module for printing off the prescription, which would be useful in case there is no drug in the hospital, so that they can maybe go out and purchase from a private clinic. So we felt that this is a key issue given the huge stockout status that we usually record, so that once the medicines are not available in the facility, you can print off the prescription form and the patient goes with it. We also observed that CT equipment, MRIs were installed, and so oxygen plants were also procured. These we found them at various regional referral hospitals, but these had not yet been installed. The picture over there is the maternity ward were delivered with support of AMCHIP. Then the key issue which we used to take note is that there's laxity among internal auditors and poor sharing of information on the specification of the procured equipment for the health facilities under UGIFT, AMCHIP, among others. Equipment which was not consistent with the specifications. For example, we had cases where Macintosh chairs so as people took interest to know what is it that we had planned to procure, and this declined to receive some of this equipment. Not to mention the suppliers but we also took note of such suppliers who were delivering. Some of them are using clay bricks and others, these normal loam soil bricks, which are not up to standard. And there was no or limited evidence of presence of the clerk of works, much as these are recruited and paid. When we would find out when did they were last here, in most cases we would not find them, but also when you would ask when were they last year, there were no clear responses. So there's an issue of weak monitoring and supervision to ensure that actually we can get value for money. Then those are the oxygen plants that have been put up at regional referral hospitals, which have not yet been provided with the requisite electrical installations. And again, for us, we are concerned that this would be a loss of value if this takes so long. And Madam PS and Minister, when I was in Kabale Regional Hospital at the time, there was no oxygen in the hospital, and they were running around the district to see who could support them to get oxygen from the lower health facilities, while this equipment was delivered there. But good enough, UNICEF had intervened to support them installation of some oxygen plant. So this can... Yes, so I think the round of applause for UNICEF for supporting. In terms of improving still functionality, I wish to discuss the issue of stockouts. Despite the excellent utilization of funds by the national medical stores, performance was poor in terms of availability of these medicines. This suggests that NMS perhaps procured all the medicines as planned, but they fell short on distribution of these medicines. And the stock of the 41 tracer medicines averaged at 28% in the last 3 months of the quarter. From April to June, only 28% of the facilities reported to be stocked. So you can imagine how huge the effect was. And particularly for blood, it was at 17% for the transfusing facilities, while overall it was 45% for the transfusing facilities. Again, key to note here is that even among the top 5 that were available between April to June, they were below 50% available. And you observe there that at Metha, I was at 59 and sulfadoxine at 42. And these are for management of malaria, of course, which suggests that there's input from Global Fund here. So the question is about in the other areas. Then another issue really to note is that for all the facilities where we visited, the Center 2s, 3s, these received 4 out of 6. And in all cases, they received less than the allocated budget. And sadly, also when we visited Aleptong district, we observed that the attestate that had been delivered for management of complicated malaria, this remained in the containers of national medical stores at Aleptong district for several weeks before they would eventually. The time when we were there, that's when we met with the NMS team, and that's when they were now pushing them down to the health facilities after being stocked out for a long time. So we're concerned that why did they deliver and leave in the container? I mean, and then the last mile delivery, what happened to it? So we're really concerned, especially amidst the huge stock out levels. Madam Minister, PS and DG, I think it is critical maybe that a multi-sectoral maybe committee really investigates these issues about availability, stock out, so that we can get a fundamental solution. Because the issues of funding from our side of the ministry, that we're not providing money in time and all that, but I feel that this is an issue which we really need to address squarely, to address these issues of availability of medicines. Under the reduce the burden of communicable diseases, This performed well at 75%, with support from Global Fund and Gavi. Immunization performed well. HIV population cascade of 92 know their status, 85 were an art, and 79 their viral were suppressed, suggesting that a steady movement towards 9 drugs, again related to delays in provision. And reduce the burden of communicable diseases, we have already observed that community health extension workers, these were implemented in Mayuge and Lira, and new vaccine introductions were also done, although these didn't perform well, mainly because of low capacity of staff to administer the new vaccines, but also there were issues of late accountabilities from the districts. The district health officers here, sometimes you take too long to account for the Gavi funds, and this definitely affects the disbursement of funds. Then there was this issue of insufficient disbursement of funds for the queues. While we were in Mayuge, we were informed that these had just been paid for a few months, and of course this somewhat affected their morale in terms of undertaking the mandate. And prevent, control communicable diseases. We noted that the oncology center in Gulu was substantially completed for the first phase, and the picture there is some of the equipment that was delivered and installed. So the first phase was completed and under DLP, but the second phase was ongoing. At the Heart Institute, open heart surgery is performed at 193%, 177 for lab tests, and 154 for catheterization, among others. But whereas we observe this good performance under the Heart Institute, the need for service remains huge. So there's a lot of unmet need or unmet demand for cardiovascular services. And this is something which really we have to address, hoping that maybe after establishing the new center of excellence, or if we come up with other interventions, we could try and address some of these issues. One of the poor performing interventions was increasing financial risk protection. This didn't perform well, achieving 49 of the set targets. But the good news is that the bill was cleared by Attorney General and was due for presentation. We hope this is completed in time. And because of slow implementation of activities, there were issues of mischarges. Under that intervention for health insurance, because the money is there, there is a tendency to, if you need to pay for something that is pending, you can do, we observed that was done because maybe these works were not HIV. This performed well, and this was mainly implemented by the AIDS Commission, where they supported the Uganda coordination mechanism to undertake oversight roles and also provided technical support supervision. This performed at 60%, and FP commodities were provided through NMS and GMS. And however, we observed that there was a less incidence of gender-based violence in Karamoja, but high in other regions. Kasanda, for example, had abortions due to GBV recording highest. Mubende, STIs due to GBV came highest, and Mukono had injuries due to GBV recording highest. The MOH conducted an integrated support supervision to the 4 regions of the country. So the key to note is the weak link among the different referral pathways. In our interaction with the DHOs and the community development officers, these continue to work in isolation in the issue of addressing GBV. because there are clear referral pathways through police, through to the health facility, but we realize that these are working in isolation, and consequently, there is underreporting of GBV prevalence. So an issue of coordination really needs to be looked into to ensure that we achieve holistic development. Increasing access to safe water didn't perform well as well, despite some works which were undertaken, as you observe in the pictures. Some water supplies had been started on in the financial year. Then there was an issue of delayed issuance of no objections from the funders. And I know that our funders are here. There is a key issue of some delayed issuance of no objections, which somehow affects implementation of activities. Under promote health, research, innovation, and technology, we noted that UVRI undertook development of 2 COVID-19 vaccines. These were COVID-19 inactivated and the anidovector COVID-19. There were also studies being undertaken by the Science, Technology, and Innovation Secretariat. We also observed that Mulago National Referral, Butavika Hospital, undertook research, while, and also UCI and Heart Institute also carried out research and published most of it. I point that we observed that the joint manufacturing of the different vaccines using the same pipeline for these critical stages of the 2 COVID-19 vaccines had issues of substantially increasing risk for contact. And the first one was the misalignment of indicators in the program-based system with the mandate of health institutions, leading to inaccurate reporting and or failure to appropriately report on the outputs and outcomes in the PBS, in the program-based system. For example, when we visited Butavika, they didn't have any indicator on mental health in the PBS. So in our interaction with them, said, how do you assess performance? How do you know you are working when all the indicators don't relate to your mandate? So it's one of the emerging issues which we noted and requires redress, especially as we do the next national development plan. And this was the same for other facilities. So they were having challenges of how do I report? And in many instances, they would just input figures. So you see, target 20, achieved 20. So you ask 20 of what? What did you really do this activity? They say no, of course we needed maybe to just populate. So it's a key issue, an emerging issue which we really require to deal with. The National Planning Authority, Minister of Finance, and Minister of Health, an entire program to address this issue, to ensure that there is accountability. The other issue is inadequate staffing, which continued to constrain service delivery, especially among the recently upgraded facilities. Again, there were no health workers in these facilities, and so they kind of remained, for lack of a better reference, white elephants, because they could not offer the services. But of course, there were some issues of the suspension of the recruitment, and we are hoping this can be lifted to ensure that these are recruited and operationalized. The third issue, dear ladies and gentlemen, was the continued use of the IPPS, the Integrated Payroll Management System, in most government institutions. And this provides an avenue for abuse, or an avenue, because it has dummy cost centers, and therefore can permit abuse, including ghost workers. I'm sure you heard about the issues in Intungamo. This is related about having an IPPS which allows dummy centers. So if you find somebody unscrupulous, they can input things that don't relate, because you can find a cost center that is not in that district, and then somebody is able to fit in the health workers in line with the structure. So that's another emerging issue, and we hope this can be dealt with through migration to the HCM, the Human Capital Management System, is more robust in terms of managing this issue. The third issue was persistent cost and time overruns across projects, and this related to delayed procurement and completion of construction projects, especially under UGIFT and UPDF facilities. I know we've been having issues under UGIFT for delayed return of the unspent funds, and I think this Minister of Finance has decisively this time dealt with it to ensure that they return the money from the 3% of the supplementary budget. But again, key to note is that we need to implement these works in time to avoid this constant returning of money. But also the other issue we observed is that the UPDF contracted works didn't take off in many instances last financial year. When we visited Kabale district, they transferred all the money to the Ministry of Defense, and they had not yet mobilized. The same thing was for Kambuga and Kapchura hospitals, where they transferred the money. Then another emerging issue was delayed issuance of no objections. I've already alluded to this from especially World Bank finance projects and other external funders. Last but not least, under emerging issues is the mandate-related challenges, especially in regards to training versus deployment of medical interns and senior house officers. We also observe this as an emerging issue because we know that the training institutions under the mandate of the Ministry of Education, who I think are currently the program led, but now when it comes to deployment, these are handed over to you. So we observe that we need to strengthen the linkage between these two to ensure that, ladies and gentlemen, we also identified, as I come towards the end, we also observed some program risks and mitigation measures. The first one, that the HCM is fast-tracked, then the expiry of and wastage of reagents, we advise that there is prioritization. Then among the issue of laxity among internal auditors and the poor sharing of information, we recommended that this information should be shared with the facilities so that they know what they're expecting, so that the unscrupulous suppliers don't take advantage and bring things which you know you didn't actually buy, but so that they stop exploiting that issue which we identified in some facilities. In terms of conclusion, the performance was fair. However, investments in infrastructure, including improvement in remuneration, didn't fully translate into improved service delivery, and there were notable delays in execution of works. But we again note that these challenges are not insurmountable. They are within our means, and we can deal with them and be able to improve service delivery. In terms of our takeaways for the next budget, the first takeaway is still, again, I will emphasize recruitment to ensure that we can actually operationalize these facilities. And then the second one is teleradiology as a solution to the shortage of specialists. Because we know these scans were distributed to different regional hospitals, but again, there are no radiologists in most of these facilities. So we recommend that we fast track the operationalization of the National Center at Mulago so that they can help interpret the images and ensure that we can offer services. The other takeaway is that we walk the talk of disease prevention and health promotion. We are cognizant of the fact that we all agree this is what we have to do, but we need to make sure we walk the talk. And lastly, the recommendation is that we fast track the national health insurance scheme so that we can reduce the high out-of-pocket expenditure. As I come to the end of my presentation, I like to ask, as a health worker, you should ask yourself, what are you going to do to add a building block on our theme for this year? What are we going to do? What part are you going to play to ensure that we can move forward? I thank you very much for listening.
Okay, thank you so much. Now I want to, I suggest that we also get the other presentation, and then we have one discussion, if this is okay, or we are very tired. Concentration span 0? So we take one, and then can we have presentation of government annual performance report in the human capital development programs? We are giving you maximum 10 minutes. I hope that will be sufficient.
Honorable Minister, PS, colleagues, ladies and gentlemen, my name is Vincent Sozi. I work as Assistant Commissioner for Statistics, Monitoring and Evaluation in the Ministry of Education and Sports. I'm going to give a brief overview of the government annual performance report on the human capital development program. Chair, as those are the quick outlines, and I'll ensure that I fit within the timelines. In terms of scoring and methodology, the annual government report, performance report, is an output of the Office of the Prime Minister, and our job as education, which heads the human capital development program, we just carved out the human capital development component, which I'm presenting. And these are the ratings that are normally used by Office of the Prime Minister. Chair, the human capital development program has a number of goals, but specifically the key components or aspects are basically education, health, water and environment, and social development. So the program includes the Ministry of Education, Health, Ministry of Gender, Labor and Social Development, as well as Ministry of Water, Environment and Natural Resources. So the core goal of the program ministerial level as well as human capital development program level. So generally, that is just how we are doing for each of the different results areas. We are able to see the overall performance, which is already highlighted, and the areas where we, but of course what I've learned, a good takeaway personally, you can have a red, which is a good red, but I don't know how we can be able to qualify this so that in the assessment we are not penalized. But that's how we are assessed. These are so many results areas, and they total up to 28. But overall, the performance was not very good. Hopefully, as we go to the last period of the NDP 3, we should be able to catch up, but also ensure that the unassessed indicators have data so that we are able to assess. Or we should be able to review the indicators so that we have clear indicators for which we can be assessed. I want to go to the output indicators, Chair, in the interest of time. All these are outcome indicators. In terms of output indicators, the performance was relatively fair. Overall, the program achieved about 57% of the outputs within that financial year. And when you add on those that are moderately satisfactory, you come up to around the 64-65%, which is not so bad. And we can see those that were not achieved, and you can see those for which there was no data, at least only 13.5%. So that is the overall for the outputs for the entire program. Sometimes the statistics can hide a lot of valuable information, but when you open up those percentages, because now we are looking at all the votes, and when you look at the votes, a quick calculation shows around around 57 votes for the entire program. But you see at least 14 votes achieved over 75% of their outputs, and 23 achieved between 50 to 74% of the outputs, and only 20 votes achieved less than 50%. And overall, I've already shown the picture of the entire achievement. Those are the details per vote, including each vote, because I noticed that within the health sub-program, you have so many votes. So is education. So in their assessment, they are looking at each of the votes, and they do the assessment. We can go to, there are so many, as I said. So broadly, in terms of summarizing, we have already seen that we have 23% of the outcomes that were achieved. Very few, 4.7, that were moderately satisfactory. And we see 23% were not achieved, and the majority, 50% really of the indicators were not assessed due to lack of data. And this is a huge challenge which we need to address as is. And good progress was highlighted in the area of average years of schooling, which increased from 6.1 to 6.8 years, and also the survival rates in the grade 5, that is P5, which improved from 55.7 to 61.6%. And the number of susceptible to 1.21 in the financial year under review. And also they note some of the reasons for the poor performance as highlighted. And if these are handled, definitely we should be able to have good performance moving forward. Chair, I don't know whether these are quite visible, but they highlight a number of issues which we can look at and see how to move forward. The emerging issues at a program level. But before that, we just have to note the Human Capital Development Program is getting a lot of pressure from the population growth. The population growth is exerting a lot of pressure on the program, on the services that we deliver. And I noticed that most of these emerging issues hinge on this. And the first one is the shortage of, and they make some suggestions in the area of attracting skilled personnel, as well as retooling, training, personal infrastructure to improve access to the services that are delivered within the program. And of course, one of the key issues is that we need to take stock of existing infrastructures and facilities in education, health, water, and environment to ensure that there is proper planning. But again, I noticed that the government is doing a lot of intervention in this area. I saw you gift 105 secondary schools in sub-counties without government secondary schools. And our target by the end of the last phase, we're supposed to have 259 secondary schools. So we believe that in the area of providing infrastructure to ensure access to these services, government is making a tremendous effort to bridge the gap. Then they also highlight issues of increasing technology and automation that puts some jobs and skills at risk of replacement. And one of the key issues they highlight to be able to embrace and leverage on this technology, but at the same time review the laws and the policies and regulations to have clear guidelines on how we can leverage on this rapidly increasing technology. And lastly, Chair, is the issue of lack of dedicated human resource capital development secretariat as envisaged in NDP 3. We are supposed to fast track and have an independent secretariat. And what I can say is that the Ministry of Education put aside funding and recruitment of staff to handle the secretariat for this program is underway. And once this is done, we should be able to have a fully fledged secretariat that can then work with the different sub-programs and MDAs to ensure proper reporting and monitoring, so to say. And finally, the issue of data, which, as you saw, is a big problem. We need to improve our data systems at a ministerial level, but also even at a program level. And we really take note of this. Have a task force that that can look into this and be able to report fully on our performance. I thank you so much, and thank you for the invitation. Thank you very much.
Thank you so much. I request you take a seat there so that we get a few questions and we close this session. Any question? Okay, we have one hand, but I want first get the questions. Any question? There's a question here. There's also a question behind.
Thank you very much, Chair and the presenters. I'm Dr. Vincent Bweta, and I work with Uganda Health System Strengthening Activity. My question goes to the presenter from Ministry of Finance and Economic Development. As he was giving the recommendations, or which institution is he channeling the recommendations? Actually, many of them, I thought there were also recommendations to his ministry as well. So I was wondering, to whom is he channeling the recommendations, the allocation to the constructions, making sure there's allocation for wage? So whose recommendations are these?
Country, I think, has 4 niches. And I was wondering at what level, he was reporting, because I know for sure that there are niches that have been, supported at the different levels, beyond the number that was reported. Is this at a national level? What standard of niche, maybe if he has parameters that he was using to, to categorize those kind of niches? Thank you.
Thank you. My name is Dr. Laro. Mine goes to the Human Capital Development Program for Ministry of Education. One of my key observations is one of the assessment tool. Because if they take that, if you score less than 75%, it's taken that is not achieved. And yet I'm looking at already 74% is really already a great achievement. 49% of the indicators were not assessed. So it would have been better to assess the program based on the other 50% indicators which were assessed. So that what will become like almost performance of 24% would probably actually be a performance of what? Probably close to 50%. Then because you cannot, it will not be fair for you to assess only 50% and then you use it to make an opinion for the whole performance of the program.
Oh, okay. Also, I just wanted also I will ask in the long. Oh, there's someone.
Thank you, Chair. Tom Aliti
from Ministry of Health. My question is to the Human Capital Development Program. Since the lead is Minister of Education and Sports, in view of the new health facilities we are constructing, and also the facilities we are upgrading from one level to another, is there a way as Human Capital Development Program we can get a special waiver for recruitment of critical staff within the program next financial year? Because we cannot leave these health facilities as white elephants. Is there a way as a program? No, a program for not only health, but also Ministry of Education and Sports. I think we should take this agenda forward and have this discussion, because when I've been in the field moving, I found so many facilities upgraded with only one staff. And now if we say we are freezing recruitment, it will be really sad news for us next financial year, especially as we're approaching 2026. Thank you very much.
Okay, just before I give the mic to the minister, I wanted to bring the attention to the Bamau person who was presenting. The uninstalled oxygen plants is a result of partial funding, and I thought that in your recommendation, I would see the recommendation on getting money so that these plants get the transformers quickly, because if they remain uninstalled in some facilities, then they will get spoiled. So we would want to see those strong recommendations from your side, because I do believe that this report is consumed by Ministry of Finance to make sure that the impact or the follow-up or the solutions are provided, especially where clearly the financing is lacking. On the equipment that is not meeting the standards, I think after you have made your recommendations and other people have answered, like has finished, I want the engineer team to comment about this equipment that I've heard that is not meeting the standards that was delivered, and then we need to follow up. And it would be good actually to know which facilities. It will help us so that we are able to follow up on this issue. Thank you very much. Over to you, Honorable.
Thank you very much, Chair. Allow me to appreciate the two presenters. I have a couple of comments, and you will bear with me, but I will try to make them real quick. First, I will start from an observation. While the Human Capital Development and Bamau are supporting the efforts of the different ministries, I think we need to have more coordination. Because when you come and make a presentation on statistics that are varying from the statistics presented by the DG as annual health sector performance, then my question to you would be, what is your source of data? Because the Ministry of Health has a known source of data. We have the Health Management Information System, which is the DHIS2, and that is the source of our information. So you need to coordinate yourselves so that you stop having conflicting statistics. You leave everybody in the room wondering what kind of, which one is the true one? I hope you get my point. So as far as I am concerned, you are a budget and accountability monitoring unit. I would have expected serious things on budget monitoring from you rather than on program. And some of the things that I would have expected from you is, one, funds are being returned, recruitment is not being undertaken. Why? You go down, you find out why. You come and tell us this is the amount of money that was returned in this year. We would have recruited this number of people. These are the reasons. That is budget monitoring. You would have gone on to tell us why there are delays in giving no objections from projects. Project funds are not being utilized. World Bank so and so delayed to give a no objection so that the projects can continue. This is the reason why. The Karamoja project is delaying. This is the reason why. But now when you go to talk about my statistics on immunization, on infertility, on what, when the DHIS2 has spoken, when the UDHS has spoken, then I get a little bit confused. That's why I'm asking you, what is your source of data? I hope you understand me well. So there needs to be coordination between all of you. 2, this is for human capital development as well. I want to appreciate your presentation, and you went ahead and quickly put a disclaimer that you actually lack statistics. You see, when you start giving statistics, you have to tell us the baseline. You have no baseline, you have no targets. The statistics are just appearing from somewhere. And I begin to ask myself, and at the end of the day, education sub-program has no system to collect data. Ministry of Water, no system to collect data. Gender, no system to collect data. But you have statistics. So where are they coming from? So my humble appeal to you is that next time, come with baseline. This is where you were when we started the program. I hope you understand me. This is the target we have set for you. Move from where you are, come to this target. Then why haven't you achieved it? Just like the DG was giving statistics. That is when it begins to make sense. Otherwise, your role is to address very critical issues that actually affect social determinants for health, education, water, labor, and so on. But I am not seeing how they are getting, how the human capital sub-program is going to come up. If you relate this to the first presentation of the professor, that Uganda has very low human capital. And there are so many issues surrounding that. So if you don't have the baseline and you don't have the target, then it becomes very difficult to assess. Lastly, my humble appeal to you is that you reach out to the various ministries and departments to show you their sources of information so that the data collection can be harmonized, and then we shall have a fully flowing monitoring system for human capital development now that you have resources and you are beginning to recruit. Also address the system so that whatever information is collected in health is filtered to you. What is collected in water is filtered to you. And I can ask you a question. For example, Uganda as a country, Uganda is actually the richest country in terms of fresh water, the richest world over. But we still don't have water even in our villages. So, how many boreholes do we have at present? What target have we set for next financial year? How are we going to meet those targets? Those are some of the things we'd love to see, so that I can relate it to why we have orophycal diseases, why we have diseases that are related to unsafe water, and so on, so that we have a link in the human capital development. I hope what I'm talking makes sense to people. Yeah. Thank you.
Okay, over to you.
Thank you so much. I'll start from the Minister's remarks. First of all, of course, my presentation is available, and I'm not very certain of where the conflicts in statistics came from, because in my opening remarks, we even applauded you for achieving maternal mortality rate for the NDP targets, infant mortality, and missing on neonatal. So, Honorable Minister, with all the due respect, I was not sure the conflicts, but maybe I'll study the report more closely. But also just to add, when we are doing our monitoring, we do monitor through the entire results chain, from inputs, activities, outputs, outcomes, and the possible impact, to be able to link the resources to the result. So it may be difficult to just come and only talk about the budget like you're proposing. But it's an issue which I've taken note, maybe to just continue collaborating with you.
Let me just cite for you one area. Your statistics on the 90-90-90 progress. If you look at them and you look at what the DG presented, maybe your statistics were for last year or the other year, I don't know. They are very different. You go back to most of your statistics and you compare with what DG presented.
Okay, I've taken note of that, Minister. Then the issue of PS, on the issue of funding, yes, we take note of it. But in my presentation still, since we run a cash budget, Minister and PS, you know, that's why we're thinking that if we don't have enough money we've given to you, can we handle, say, maybe Gulu and complete it, and then move to Mbale and complete it, then put up things in different places, and they're at the same stage but unable to continue. But of course, you have a valid point of the funding, but as just a proposal that if we are constrained, can we put all our resources to address a particular area, then move to another place? But we take note of the additional cash requirements which you propose. The Undersecretary, you had a comment on the NICUs. From our monitoring, we appreciated that there are what are known as newborn special care units, and then the neonatal intensive care units. These vary in standard, level of care, and ability to take care of the neonate, a baby who is under 28. And the information we received from the ministry was that currently only 4 qualify to be identified as neonatal intensive care units, and these are in the Women's Hospital Mulago, the National Referral of Kawempe, Nsambia Hospital, and Chiwoko Hospital. This is the information we gathered. While the special newborn care units were in Bwera, Sekanyonyi, Chiwoko, Mpiji, but the others, there are some others that are still ongoing to ensure that there is an improvement in the management of NICUs. Then somebody from Health Systems Strengthening, you were asking the person to take over the recommendations, but I thought this was clear. This is a presentation for this sub-program of population health, and the title shows key takeaways for the next budget. So the expectation is that, but maybe in future we can put Ministry of Health, Ministry of Gender, but these are different votes, remember, but under the same sub-program. I think those were the main ones I submit.
Okay, thank you. Thank you for the issues raised. There was an issue of why do you handle indicators that have no data within the assessment? that is an issue we need to raise with the Office of the Prime Minister so that we qualify the overall assessment. So it is a methodology issue, but right now in their methodology, they look broadly at the indicators that were originally set, but it can be escalated and discussed. Then there is an issue of recruitment, which affects not only health but also education. Going forward in the handling of the Human Capital Development Program, we are supposed to have an active working group at a higher level, where if there are cross-cutting issues, they are escalated at that level, discussed, and then the solutions are found. And that's why the idea of affect health, education, all of us within the program. So we should be able to tease out solutions, like the issue of staffing that you've raised. It's a pertinent issue. So I believe it could be one of the candidates for discussion at the higher level, where all the ministers and the PSs are really part of the team. Then I agree with the Honorable Minister. We need the proper coordination to ensure that there is consistency. I'm a statistician, and I'm really concerned on the quality, consistency, timeliness of data in terms of reporting. And as the report was being presented for health, what came to my mind, the new UDHS, I heard it was published in September, and then I was thinking, when was this report generated? I think it was generated 1 month before. Could the results have turned some of the reds into greens? So I think in terms of statistical reporting, issues of timelines and reference period when data is generated and reported is very, very important. So, and issues of harmonization, I think this is an area we need to take up so that we have consistency and accuracy for the users of information that is generated. Thank you so much.
Chair, there was another question that brought here for me. If I can, the question was, given that human capital development account for over 60% of the budget, can we consider splitting it into health and gender, education and water? Just the person who wrote the question didn't indicate who they are and maybe where they work. But the information is available, because finally the disbursement of the system of IFMIS or others eventually come to the vote. They come to an entity. So we're able to split the 9 trillion and know health got 4 trillion, and of the 4, Cancer Institute got this. So the information is available, and you can reach out to me, and I for sure volunteer this information. There were some other 2 comments, but they were directly to Director General, and I've given him the issues. Thank you, Chair.
Okay, there is someone also here who wanted us to comment about the delays by Solicitor General to approve contracts for local governments. I think that one will not be able to speak for Solicitor General, but what we have been doing
where the districts has a challenge and following up with Solicitor General, and it is taking long. Some that have reached out to us, we have followed up with Solicitor General, and they have actually acted. Yes, there are delays in Office of Solicitor General, but it is not significant enough to cause really, we should not push the blame to Solicitor General as the, as the main thing. I want engineer team to comment about equipment that was procured.
Yeah, thank you, Chair. Thank you, Chair, Honorable Minister and members present.
First of all, who procured? Who made the specifications?
Okay, thank you. There was, the first question was about the use of local bricks instead of the specified concrete blocks. I want to clarify that the Ministry of Health provides approved standard designs for construction, which has the architectural, structural, mechanical, electrical, and including the layout on how a facility is supposed to be constructed. Any other design which is not from the Ministry of Health can only be approved by us because there are normally some challenges in trying to fit what we have designed as a standard into some spaces. So I have seen the pictures there. I have noted, and he has pointed out that there are no indications of adequate monitoring and supervision. But I also want to make it clear that under UGIFT, these designs are provided to the local governments in advance. The bills of quantities are provided to them. The specifications are provided to them. We normally have meetings before implementation. Now, during the procurement of contractors for construction, we work together with the local governments. They direct work supervision to ensure that the designs that have been provided are implemented the way they are done by local governments. We have so many health facilities across the country, so we expect the district engineer, and in the projects we normally have provision for employment of a clerk of works who should be attached to each of these projects. But I've noted the gap in supervision and monitoring by the center, but the direct work supervision on a day-to-day basis is supposed to be done by local governments. As Ministry of Health, we can't do that. In terms of specifications for medical equipment, I also want to inform the House that we have standard equipment list and specifications. This is a public document. Even when you go online and you want to know the standard equipment list for Health Center 3, they're available, Health Center 4. But most importantly, when we are procuring medical equipment for Health Center 3s, Health Center 4s, general hospitals, regional referral hospitals, we involve the end users. We provide the specifications to them to look at it. Where they need to have input, we normally work together with them. Now, for as far as the Health Center 3s are concerned, during the evaluation, we have the specifications on the side and the bidding document. The local governments are all invited, and they are in that evaluation. Now, what takes place is that during the delivery of this equipment, the districts have the list of the equipment that are supposed to go to each of these facilities. They have them. They have participated in the evaluation. So at the time of delivery to the facility, the staff from Ministry of Health are not there. We only go later to verify, but the specification and everything is with the local government. So we note that if there are some equipment that did not meet the specifications, we are going to follow it up. We also do due diligence on medical equipment before they're delivered. And we do it together with the local governments, including doing due diligence on the contractors for construction works. Chair, I hope I've clarified on that.
But I still request that engineer or team take note, get the specifics of the issues that they found, because we want to know that those issues have been addressed. If the district received and accepted the things that are not meeting the specifications, that must be reversed. And for me, that's what I want to hear, and we give ourselves timeline so that it is rectified, because we should not accept the things that are not in our specifications.
Yes, that is noted. I will quickly follow it up and report.
Okay, thank you. So I think we've come to an end. Thank you so much. Thank you for your patience. Tomorrow we'll be able to convene here at 8:50. At least we shall be starting at exactly 9. Thank you very much.